right. Morning, Jackie. If you can hear me, I can see you.
Yes, I can hear you and see you.
How are you, Jackie? Okay.
Thank you. Yes.
Good. It was brought to my attention by a couple of non-exec colleagues that there might be a problem with these diary entries, Jackie. For some reason, the calendar entry had disappeared from my diary. I only noticed last night, and obviously that contains the link for the meeting. You know, hence me getting in touch with you last night. So I think maybe we just have to have a look at that and see if it's a problem, because, as I say, a couple of colleagues have said they've had the same issue.
Yeah. Well, we'll take a look at it.
Yeah. Good morning, John.
I had the same problem. On my phone diary, it said it was cancelled, the meeting, and on my iPad, it was still in.
Right. Yeah. No, I don't know what's happening with that there. Yeah.
I'll let Sheridan know, and she can investigate.
Yeah. Thanks, Jackie. I mean, hey, by the way, I am very grateful for the fact that you're obviously both in perfectly early enough to sort it out first thing anyway. But obviously, as I'm finishing my preparations last night, I'm thinking, I hope I can get into this meeting. Yeah.
Good morning, everyone.
Good morning. Hi, Barry. Hiya.
Morning, Barry.
Morning, everyone. It's Mohammed.
Hi, Mohammed.
Oh, hi. Good morning, Mohammed. And thank you for your note. I realise you're on the phone first and you'll be catching us by video later. Thank you, Mohammed. So, shall I start asking for a few hands up here? Yeah. Let's have a look at our exec colleagues there. So, Paul, good morning. I can see you're here. Good morning. And Sajid. Yes, good morning, Sajid.
Yes, I'm here.
Thank you. And Brian, good morning. I can see you. Yeah. And is Karen with? Yeah, Karen, good morning.
Morning.
And Pat. Yes, good morning, Pat. And John Holden. Have I seen John yet? Oh, good morning, John. Thank you. Yeah. Got you. Mel, I know, is slightly delayed. She has a meeting with Richard Barker this morning, the regional director. So she's hoping to join us within the first hour of the meeting. But she's obviously tied up with something reasonably important there. And Matthew, good morning. Are you with us? Yes, I can see Matthew. Thanks very much. Yeah.
Morning.
Thank you. Good morning, Matthew. And my non-exec colleagues, I can see that Barry is here, and I can see that John is here, and Julie, and I missed Ray. So good morning, Ray Smith. Yeah. Good morning. Thank you. Glad you're here. Selena, I think Julie I've seen as well. Yeah. Selena, I'm looking for. Yes, I can see Selena's here. Thanks. And Trudy, good morning, Trudy. I can see you're here as well. That's great. And Mohammed, I know, is here as well. That's great. Okay. So I think we have a full house. I'm aware we've got some guests, but I'll perhaps let Karen introduce them in the first place. So given that we're all here, shall we make a start? It's 8:30. I've just gone. Good morning, everybody, and welcome to Bradford Teaching Hospital's Board of Directors meeting in public, our open board meeting. Can I just remind all colleagues that this meeting is being recorded and will in fact be published on our YouTube site tomorrow. So in the absence of being able to invite members of the public to actually join us at the moment into particular meetings, this is a way in which we're trying to ensure there's proper transparency. So you know that we publish the agenda items early, we invite questions should people wish to raise those with us, but we also publish the meeting. And so that's going out today. And thank you to the corporate governance team who are making that possible. So just a reminder to colleagues that that's being done. Thanks everybody for your attendance. We're in very strange times, and we're going to, I'll go through the mechanics of the meeting. I think perhaps after we've heard from the urgent care team, we'll perhaps turn to our colleagues. Given that they're an urgent care team, I guess they've got better things to do than sit with the board for too long. But it's fantastic to have them here, thanks. The non-execs in particular, so as a unitary board, we have a joint responsibility for the success of the hospital. So it's execs and non-execs take a joint and equal responsibility. And of course, the challenges of the last 8 or 9 months have been that non-execs have generally stayed away from the hospital, and rightly so for infection reasons. But it's meant that obviously it's been frustrating for us in terms of the usual visits, discussions and chats we'd want to do on the ground, so that what we're discussing at board makes sense to people on the front line. And that's obviously been a source of frustration for us. So I'm delighted, I think, in that context, to welcome members of the urgent care team, who I think are going to talk to us about emergency care this morning. And I'll pass to Karen, perhaps just to orientate us, introduce the team, and we can get into the first half hour of the meeting being hearing from our colleagues in urgent care. So Karen, shall I pass to you now?
You can, with pleasure. I'll be very brief. So as part of the regular CBU to exec meetings that we've been having, we thought it would be really good as a board if we could see the different CBUs presenting what they're doing, what they've achieved, what they aspire to achieve. The urgent care CBU was one of the first ones that presented. They were extremely progressive in the thinking. And you'll remember that this CBU was one that about 18 months ago we started to put some defined development and OD support in. And what you'll see is when the team present now is that that's really paid off. And what you've got is a real strong, cohesive team that are united in patient benefit and staff benefit as well. So I'll pause there because I don't want to steal the thunder, but I'll hand over to Sam Khan, who is the CD for this service. Excuse the drills outside my office, by the way, to take it from there.
Thanks, Karen. Good morning, Sam.
Good morning, everyone. Thank you. And thanks, Karen, for that lovely introduction. And thanks to the board and the execs and non-execs for inviting us to talk to you and get to know you. Do I need to share my screen? I've got it across 2 screens, just that we have got a very short slide pack for people to have a look at.
Perfect.
Yes,
and that should work. Yeah.
You say it should work. Let's have a go. That one.
It has indeed, Sam.
So if I go to that.
Yeah.
Right. So as Karen's alluded to, I think we were the first CBU that was put together, and it's gone through a heck of a lot of change. But just for clarification, the CBU, everyone keeps calling it urgent care, but it's urgent and emergency care, and it's a combination of acute and emergency medicine in its first iteration. And as you can see from the structure there, we've got some defined roles and some resilience in our numbers, I think, is what we've developed over the last sort of 18 months. And as a team, we have come together, which I'll talk about in a little bit. But the essential structure is acute and internal medicine, of which I've got a lead clinician, a matron, and a business manager. And that support is integral to allow me, Simon, and Lizzie in our managerial, nursing, and medical leadership roles to have support in each tier. That is replicated in the emergency medicine team with Dave Greenhorn, Emma as the matron, and we've just recently appointed Fiona Backus, that I think some of you will be aware of from her previous corporate role. So that's quite exciting for her and for us to be able to attract people that want to join us. And then the other part of our CBU that often gets forgotten about, even though it's utterly integral to what we do, is the command centre and the patient flow part. And that's the bit that is the all singing, all dancing flagship of the organisation that I think we don't sing and dance too much about, and we probably need to. And sat in there as the leaders, the clinical leaders, are our Brad as the medical director for the command centre, and Sarah Buckley as the nursing clinical lead. And to some extent, Sean is in there as well. Sean Milburn helps support them from a managerial perspective. And then they've got a team of site matrons that work 24/7 that provide us with the clinical expertise in and out of hours, 7 days a week. So that's just a very quick overview of what we are. Just flip to the next one. So, as I've just said, the CBU today is a combination of emergency and acute medicine. And our biggest win for our patients is the fact that we've actually brought these two services much closer together and aligned as one big team. And it's been an interesting journey and a bit of a challenge with the issues that we've had with capacity and then COVID. However, at the end of this 18 months that we've got through with me being in charge, we have improved the way our patients move through the organisation and their overall experience. And that's come from hard work and development of different techniques of managing our areas. And the big win for us is development of the same-day emergency care model. Now, before COVID happened, we had a number of different teams. So the emergency care intensive support team came to visit us because our metrics were not great. Our ECS 4-hour wait target was not brilliant. I think we're in the bottom quartile, I think it's quite easy to say, of performing organisations nationally. They came in, they looked at our 3-year plan that Sandra had put together with recruitment and the development of the vision of what I thought would be the right thing to do. And then we started to understand our footprint was not right, our staffing numbers were not right for our patient workload. And again, with the help of the performance team, the finance team, we started to develop a 3-year plan of how we changed how we run our front door. And integral to it was bringing the two teams together to work more aligned. And we've developed the same-day emergency care model. It has essentially boosted us from being in the bottom quartile to being in the top quartile nationally with regards to ECS. And despite COVID, we have still maintained that standard. Other organisations that were our peers pre-COVID, we've left them in our wake. We've also now had people coming to ask us, how come we're still performing at the standards that we were, you know, in the early part of the outbreak? And despite the second wave coming, we're still hitting the high 80s and low 90s for our ECS. And it's all down to the model that we believe is the right model moving forward. And that is about managing patients in the correct way. And we have got much better at managing our patients, not just in the hospital, but away from the hospital. And I'll touch on that a little bit later on. Integral to that, to give us that oversight and give us that safety element, the command centre is using the latest digital technology, working with not just the ED and the acute medical units, but also the other assessment areas, trying to coordinate the patient journeys and flagging up patients that shouldn't be where they should be, or shouldn't be where they are and where they should be. And that role, again, has become integrated. So the ED team, the acute medical team, and the patient flow team are much better closely knitted with more alignment than before. And as you have with all large teams, there's all elements of human factors that can cause barriers. But with the help of OD over the last 18 months, we've put in lots of leadership opportunities to train our staff up to work together. We've amalgamated those teams and leadership groups to help develop them, and bringing them together was the first step of getting them to understand one another's issues, and therefore then built on that. And you know, the adage we say, people walk in other people's shoes to understand what their problems are. I think we have lived that as a CBU, which has led to our improvements. We've got much closer working within the same-day emergency care area with a mix of acute medical nurses, emergency medicine nurses. We've even had a few people from the elderly team join us for a period of time just to understand what it is that we're doing. The other part, so that's internal collaboration. The other part that I think we've led the way on recently as part of our urgent care improvement program is with our external partners. So as part of that reinvigorated program that we've restarted recently, we are working very closely with 111, with YAS, with the CCG, about trying to minimise the inappropriate conveyances, the inappropriate attendances to the ED, and also manage the more complicated patients, of which Bradford has a huge demographic. We have a high morbidity rate for our population, high population density with a very young age for these morbidities to present at. So we have got complex needs patients. So coming to the ED is not always the right thing for these patients. And sorry, light's gone off. Sorry. I thought my mouth would be big enough to set it off, but never mind. And so managing them with the CCG's help is optimising their management. And this is a process that we've just sort of started on in more detail recently, engaging with the CCGs. Dave Greenhorn and Sean are liaising with primary care in managing appointments that the public think they may not have access to. That's a pilot that's just started this week, actually, on Monday, having dedicated slots at GP practices. So if people present to the ED, we can allow them to go straight to a GP appointment that they didn't think they could attend. Same with 111. We're linking in with 111 to have dedicated slots that patients don't need to attend the ED to, and then to contact 111. And with Yaz, again, we're piloting having a consultant that can take the Yaz calls in the ED. We've already been doing that in acute medicine for over a year, where the Yorkshire Ambulance Service can ring directly to an acute medicine consultant that's here 7 days a week, to allow patients to get the right input and not just come to the ED to end up waiting. And unfortunately, they do come to harm at times. So that's our collaboration with the external partners. The other bit that I'm quite proud of is the other external partner that's just over the hill is Airedale. So we have a non-site specific cancer pathway, which we call it the vague symptoms pathway. Other organisations call it a similar thing, but essentially it's people that don't have a clear-cut pathology that fits them into a 2-week wait target. And a lot of these patients originally were mapped as possible cancer, but what we've learned over the 18 months is that there's a lot of general medicine hidden out there. And these aren't patients that should be blocking up cancer pathways. They should be managed in a much more cohesive and holistic approach. So that's what we've developed, and I'm quite proud of it. We've developed in collaboration with Airedale. We've also influenced the change in their model of how they used to do it. They've sort of come around to our thinking and having a more, it's actually a nurse holistic-led approach with a collaboration of different clinicians discussing each case. I think one of my colleagues described it as a Senate, and having a Senate of decision makers, making sure all avenues are explored for these patients. It is essentially a flagship service that we need to be doing more of. But during COVID, we've taken a little bit of a hit because the GP activities dropped. Our numbers had dropped originally, but they're slowly creeping back in. It gives also an opportunity for patients to be redirected from the front door as well. So it's, again, patient-focused and making sure that the right things happen for them, so they're not occupying areas that they shouldn't be doing, whether it's virtual or physical. I've already alluded to the fact that despite all of the challenges that we've had, whether it's with staffing, with sickness, with COVID, with lack of resilience, as you want to call it, or attrition, as John Wright has alluded to recently, we still are able to maintain the medical care that we're proud of and still provide excellent performance. And our next step is to build on this and how we're going to move forward. And we are very much a quality-focused CBU, involving our patients in the complaints, learning a lot from our complaints, and then sharing that learning, which I know for a fact that the CQC were relatively impressed with what we'd already put in place. We have regular risk huddles. We've got a risk lead now for the whole CBU, who's a medical clinician who links in with the risk team to have formal reviews of how we're doing, what our big risks are, what our patient complaints are, just tying it all together, and then we share that across the CBU in a number of different fashions. So that's where we're at today. A little bit about our staff. So everyone wants their staff to be happy, healthy, and here, or in some cases now at home, because that's actually a better way of working. And I've found that sometimes the work-life balance is probably sometimes a bit more effective to be at home in front of the computer and banging through things. I've found that being based on the AMU in my office, I tend to get interrupted quite a lot when I'm non-clinical with clinical problems. So for me, being at home actually allows me to do all the non-clinical stuff that's essential, such as the risks and understanding the complaints and going through those things. So yeah, we need to make sure we optimize how our staff feel. We've incorporated a lot of things over the 18 months. I think we were the first service to have a pop-up Schwartz round. For those of you that don't know what a Schwartz round is, it's essentially it's an American concept from the northeast coast, where a lawyer who was dying of cancer essentially wanted to ask one of the carers that was looking after him how they coped with the stress that they had with the job, and the nurse just said, "I just have to get on with it." And based on that, he devised this. It's usually a psychology setting with clinicians to have a safe space for people that are carers to be able to express honestly and openly, without judgment, without problem solving, how they feel about what they're doing. So we started doing these Schwartz rounds in urgent emergency care, I think in November or December of 2018, and we've had a couple of pop-up Schwartz rounds, and the trust has been continuing to try to amalgamate them into the grand round type scheme, which some of us are part of that steering group. So that's the psychology and emotional part. You know, we've linked in heavily with our psychology service, with Mark Keithley, with Mary Hill, outside of the Schwartz round, because our staff at the front line have had to endure quite a lot of difficulty during the COVID period. And we need to make sure that we're able to allow them to do the job to the best of their ability. And that means not just making sure they're physically okay with referrals to occupational health and making sure they're appropriate to work, what do we have to do to modify time to work, but the bit that often gets neglected is the emotional psychological impact. And the Schwartz round, as we've demonstrated a few times with feedback, has allowed people to share things that they thought other people wouldn't know about or wouldn't care about. And it's opened up conversations which again help build the links between acute and emergency medicine, which has been integral to us working together better. The other part I'm very proud of for the CBU is the fact that we've successfully integrated into AC. We've got advanced clinical practitioners, we've got emergency nurse practitioners, we've got physicians associates, we've got nursing associates. You know, we were lucky enough with Sandra's help to put a business case together to try and recruit to all areas. The medical workforce is not just about doctors and nurses. It's about these other skilled professionals that add a layer of resilience that other services, I think, are learning from us. They've seen what we've achieved with having these. The physicians associates and the ACPs have been utterly integral into running the COVID areas during the first outbreak, where they were basically dispatched to the difficult areas because the doctor numbers went down quite rapidly with sickness and illness, and these guys stepped in and covered the gap. So their skill set is quite broad. They're very effective. They're very safe, and because they've been working at the front door, they were able to deal with quite a lot of poorly people that some junior doctors may not have had the experience to deal with. So we have been a successful model of how to incorporate a wider workforce, and we're still recruiting more and we're diversifying further. We've got paediatric emergency medicine ACPs. We're integrating with paediatric services to share hopefully a vision of having a long-term out-of-hours rota with the ACPs as their senior decision maker. So it's building in layers with other services to make it safer for our patients, not just, well, say parents then, but patients as well, 24/7. The bit that I think the ED service has absolutely excelled at is the continual education of all of its workforce. And in acute medicine, they've learned a bit from it, and we're slowly starting to pick up the momentum to make it more consistent. Is the learning, the education, the sharing. COVID has taught us a lot about what we didn't know, and also a lot about what people think they know, but they don't know. And I'll give a special shout out here to Dave, who, before his deputy role with my deputy, he took it upon himself to try and create a platform to get a message across to as many staff members as possible of what the latest things that we should be doing with regards to COVID. It was also a platform for sharing SOPs rapidly. And it's just something that, again, you know, we should be very proud of. I know Tom Walton got an MBE, but, you know, Dave's work behind the scenes and what he created, I think needs some special recognition. I suppose this is my opportunity to share that with you guys, because his model of sharing it on a WhatsApp platform and the PDFs that he put together and the files that he put together was shared not just in Yorkshire, but across the whole of north of England and even down in Wales and Cardiff. He didn't know that bit, but I shared it with my brother-in-law, who's the clinical director for intensive care down at University Hospital, Cardiff, and they've used it. So what we were doing at the first outbreak and then continue to do is unprecedented compared to other places, and sharing that knowledge and making it safer for patients, I think, is a great role modelling behaviour that Dave has demonstrated here. So I can't see him, but I'm guessing he's going to be smiling because he doesn't do that very often. The other part is the further development of our staff. So as Karen alluded to, we've had a lot of input from the organisational development team, particularly from Lily. I think it was a very, very small team in the beginning. And before Lily came quite poorly, she put a lot of effort into the leadership team. We learned together as a team. We learned to know more about one another. Some of us were very new to leadership roles. And we grew as a team together. We knew about one another's weaknesses, and we're quite honest with one another. I think that can be a challenge sometimes, but from that honesty comes trust. And from that trust, you then start to value one another more. And that line there about embodying the values of the organisation, I think as a leadership team, without getting too carried away, I think we embody the right values of the organisation and we role model that to our staff. I'm hoping the staff survey reflects some of this, but I do think that the feeling within urgent emergency care has changed quite dramatically since this newish leadership team came in. It's not just reflected in the metrics, it's actually reflected in the way you stop and talk to the staff. You know, not everyone might know who I am, but they'll know who Dave is, they'll know who Praveen is, they'll know who Julie is, they know who Emma is, and they value what we've done, and they will be a lot more smiley than they were 18 months ago, despite all the hardship. It is a slightly bigger but slightly happier workforce than I took over back in 2018. And it's not just down to me, it's not just me at all. This is about role modeling the right behaviours across the whole of the leadership team. And that organisation development learning that we had, we wanted to share with all of our staff. So we've opened up opportunities for our advanced practitioners, for our emergency nurse practitioners, for our slightly more senior junior doctors, our clinical fellows, our registrars, all of our consultant group, all of our band 7s, band 6s, and even our band 5s, and even the healthcare. So, you know, we have tried to incorporate everyone into having developmental pathways. So they've got something to aim for, and they feel more valued. When they feel more valued, they feel happier and they do a better job. And they deliver better care. So that, in a nutshell, is pretty much where our staff are at. And I'm not going to ignore the fact that it's been hard and it's been difficult, but we have done a lot of good things without realising we've done them until this sort of thing comes around, and you're able to say this to an audience that may not know some of the hardships and some of the things that you've done. So that's the staff. And then probably the most important thing is our patients. So, improve patient experience and outcomes. Well, we want to achieve that, and I think we have done to some extent. I think there's still always room for improvement. That's just probably my own foible. We have almost pioneered a rapid assessment, treatment, and placement and discharge of our patients through a lot of front door, cohesive learning, PDSA cycling, through the urgent care improvement program. We've had a lot of change in the way we triage at the front desk, what triage can happen, input into our ambulance areas, pulling patients out of the ED into the acute medical units, pulling them out into our blue zone to get them out of the ED footprint, to get them seeing the right person quickly. We've used a lot of technology. We've used the performance team. We've used the quality improvement team. And we have used the learning from the ESIST and from NHSI when they came and they did our Get It Right first time evaluation. And they actually said that pre-COVID, we were going to be setting the gold standard service for running an ambulatory type service. The plan was to have a co-located same-day emergency care unit in the ED footprint, so we could literally mix the workforces, the medical workforces, to be able to get the right outcomes of the patients quicker. It would allow people to be discharged without having to wait to get to a bed. It would allow some learning from both the ED and the acute medical teams. And that's the journey we were heading on. However, COVID changed all of that, and we had to adapt and we had to adopt a different model, but we didn't forget about the principles of that shared model. And we've had to stretch it across 4 floors at one stage to run an emergency service. And again, we've adapted with minimal fuss, with still great outcomes for patients. And we're continuing to adapt, but our future hope is to be able to allow our patients to be seen in the right part of the ED quicker. And we have remodeled the ED slightly. There are different zones to help patients understand why they're in each zone. And again, during COVID, some great work from the ED leadership team downstairs from the nursing and medical model is that they were able to corner off a purple zone to dedicate it to looking after COVID positive patients, to decrease the risk to one another, to the patients that were already in the ED. And that's in a very small footprint. On the back of that and the back of the NHS monies, we're now looking at making it even better for patients by remodelling the estate work in ED to make it much more infection secure. I'll sort of talk about that, about the future model, but that's our vision. But during this COVID outbreak and pandemic, we adapted our ED very quickly, not just the physical space, but the way the staff worked. And that was all about getting it right for the patients. We had very effective communications with staff and patients to make sure that they knew what was expected of them. The other part that we're very proud of is we've got a very robust patient complaints process now, just within the CBU. I know there's a trust-wide one, but within our CBU, we have a specific complaints officer, Fiona, who pulls it all together, incorporates the right people, gets the right people around the table to be able to then engage with the patients. And we're big fans of meeting with our patients and trying to get ahead of the game and try and answer their concerns and their complaints and give context and listen. and understand things from their perspective. And we've done it quite a few times over the last year and resolved a lot. But I think the more important thing is we've learned a lot. We've done things quite wrong and not realised, and we've learned from that. We've shared it across the CBU in a number of different formats, whether it's a newsletter, email, handovers. We've got quality and safety meetings in each section of the CBU. So our patients' voice is quite important to us, and we've made it clear that we've shared that. I've lost my train of thought now. Where we got to? Yeah, talk about ED footprint. Yeah. Okay, quality of care. So as I've just said, we're looking to make our ED footprint, our AMUs, much more infection secure. We're on with that. There's a lot of work to do, but we'll get on with it. That brings its own challenge, trying to adapt the footprint with a still high number of ED attendances despite a national lockdown. Again, people are still coming. We had 290 odd the other weekend this last weekend when I was on the day. Friday and Saturday were busy. We're still getting the message out to patients not to come. Some of them are hearing it, others aren't. We still have to run an infection secure site whilst we're doing the building work, and therefore we have to be even more active in making sure we get things right. You know, we've had some good investment with regards to rapid testing at the front door. You know, we've upped that numbers recently to allow us to get the patient placement right from the front door into the AMUs and to the wider organisation. Responding to Actus 1 and the mission for patients to be happy and healthy at home, we're looking at integrating OPAT into our service. It's been a little bit of an outlier, but we're going to bring it into the urgent care footprint to allow us to give another output for patients and actually provide it with some resilience. It's been, I think, quite a fragile service with regards to staff. So hopefully bringing it into the urgent care CBU will give it more resilience. We're looking at estate work to change part of one of the wards just to make it have an area that can be dedicated to delivering it much more robustly. And then there's admission avoidance stuff that we've sort of not really shouted about, but we've been doing it for quite a long time, and vague symptoms is one example of it, but also having hot clinics and a space for the hot clinics that incorporate into a virtual hospital model, which is kind of the blueprint for that, is the vague symptoms service, where we manage our patients away from the hospital, but discuss them as if they were in a bed regularly and keeping them up to date. And the feedback we've had from the vague symptoms as a precursor for that from the patients is very good. They're very happy that one team is looking after their care, not a collection of different people, not knowing who to talk to, having one point of communication. So I think that is a good blueprint for what we could do with a virtual hospital, just from the acute and urgent emergency care service. I haven't talked about the AMU very much, the acute medical unit. Probably should have done, but anyway. That's why I'm qualified in doing acute medicine, and the vision that we have for our acute medicine service is to have 2 high observation areas, which allows us to manage our patients in a more comprehensive manner. We get a lot of poorly people in ED that are poorly, but not quite poorly enough to require intensive care. These patients often end up staying in the ED for periods of time that are not ideal. The longer you stay in the ED, the worse your outcome. At 30 days. So looking at some of that data, we've identified that a lot of the patients on AMUs 1 and 4 are actually level 2 patients. So part of our vision is to incorporate higher observation areas into the AMU. The infrastructure is there with regards to the state. So we've got 4 dedicated areas with monitored beds, cardiac monitoring beds. The next step would be to make sure the nursing skill mix and nursing numbers are appropriate for that. So Karen has already linked in with Julie about how we're going to be doing that within a financial model that works. But it's something that we absolutely have to get right, because our patients that are sitting and waiting in ED but not poor enough do get poorlier. So we don't want to be using resources when we can prevent it from happening. So that's part of our future model of making sure we get that right. And I think we're not far from that, delivering that. The next bit is about STEC, which I alluded to before. We've sort of adapted and accommodated it onto part of the AMU where we've lost 6 beds, but by getting SDEC right, we've actually, those 6 beds haven't had that much of an impact on our capacity because we were able to turn people around quicker. We've also changed the way the acute medicine consultants work. We have completely changed the on-call rota for acute medicine. There are just acute medics on it now, which means that you get better flow, you get better decision and consistent decision making. You have a team that the nurses know very well from a consultant perspective. We've also changed the hours that we work now. So there's an acute medic on site till 10 o'clock, 7 days a week. And that was due to happen pre-COVID, but COVID accelerated that process. So that will then allow us to deliver SDEC much more consistently. And my hope is when all of this settles down, we do have a look at trying to locate the SDEC area in a more appropriate area from a medical point of view within the ED footprint. And it's something that we need to try and get back to, because that's the bit that ESIST and NHSI said is what other hospitals should be doing. So that's one of our future hopes. And then the big part for me, one of the reasons I left my previous employment was to build the clinical research profile. So with Bradford's enormously diverse population, the Born in Bradford scheme that's going on that John Wright, Prof Wright is leading, we need to be doing more in acute and emergency medicine. Now, I know that emergency medicine is already part of a number of trials with John, but we could be doing much more. There is a very large, diverse population that suffers with diabetes, that has multiple comorbidities, that we could contribute to making their long-term management better through adapting clinical research into our daily practice at the front door. And it's an area that I've already started to explore with John, and we've had a few conversations, but I'd like to have an academic research unit based in acute and emergency medicine, just like they've got at Imperial. I want that here. You know, we need to make more use of the Institute of Research over the way. So I don't want it just to be anaesthetists and intensivists. It should be acute medics and emergency medicine doctors, and even the nurses and even the ACPs. These people have got skills and masters, and we're not using them to the full extent. So that's a commitment that we want to be doing over the next 2 to 3 years. And then the thing that we always want to make sure is that we keep responding to changing needs. Our population is changing. We have got a young population. They're always coming in with things that I've never seen in other hospitals, and I've worked in pretty much all of them across Yorkshire. And we will continue to provide that quality of care by having a happy, adaptive, supportive CBU. Thank you. I think I'm done.
Thank you very much indeed, Sam. Thank you. And thank you to the team for everything they do. I know that you referred to them a lot there, Sam, during your discussion. If you want to stop the sharing, I was going to say that might just bring everybody back in. If you stop sharing your screen, that'll bring everybody's pictures back in for us. Sam, I want to, obviously in thanking you, I'm delighted that you took such a focus on staff. I just want to make that point of how important the board see that as well, that we're all about the people that are working with us. Can I, as chairman, can I commend you for the work you're doing on creating a psychologically informed working environment through Schwartz rounds? So I think that's absolutely terrific to hear that that's happening in urgent and emergency care. So well done there. And can we also, as a board, record our thanks not only to the team, but particularly note the contribution of Dave Greenhorn, which was very articulately put by you there, Sam. So as a board, we recognise that, and we note the particular contribution that Dave has made in some innovative working there. I have one question, and I'll open up for a couple more from the team. But I wonder if, Sam, if you or your team just say a little more about the role of primary care, where it works really well in helping us create a good emergency flow. The reason I ask that question is because as a board, we're trying to take more of a system approach and be an influence on the health and care system as a whole. And I'm interested in what primary care do well for us, and maybe any gaps you think that might be there as well.
I think Dave's hand went up and then went down, so I'll leave that for Dave to answer.
That would be great.
Yeah.
Okay. Yeah, Dave.
Hi. Yeah, sorry. Hi, I'm Dave Greenhorn. I have been doing a lot of work with Sean and the team, with Dave Tatham, Lucy Atkinson and the CCG, about trying to understand why patients are turning up at the emergency department who could be managed in another healthcare setting. I think initially the work has been about understanding why that's happening, and then finding different areas that are available to us, looking at what we call our DOS, our Directory of Services, Directory of Services for 111, the Directory of Services that the out-of-hours GPs use, and then working out why those resources that clearly exist in the Bradford area are not being used appropriately. And so we've started to find out that information. We've linked in with the CCG and with 111, and we're looking now at taking those resources that are available, trying to open people's eyes to the fact that those resources are available, both patients and healthcare operators in other sectors, and then get the patients to those areas. The CCG have been fantastic at agreeing with that. They have been nothing but accommodating with us. We've had regular face-to-face, well, if this is face-to-face meetings, with our colleagues in CCG and in 111 and with YAS, and through a combination of kind of agreements and compromises, we have come up with a system where we've now got 30 places per day between 4 o'clock and midnight, where we can directly refer patients from the front door to our colleagues in primary care for them to triage, and they will then do sort of GP appointments with them. We can contact 111. I've got a new service that's government-led called Talk Before You Walk, which has got issues, but nonetheless, we're doing our best to try and incorporate what they are demanding of us, and then trying to make it work for us, rather than just saying, well, we're stuck with it. We were trying to work away. So we're looking to incorporate that with our minor injury service, with Al Jones, who's one of our AD consultants, who's leading on trying to open up the minor injury service to open up appointments for patients, so they're not turning up, for GPs to have direct access into that service as well. We're also doing work with meeting with our 111 colleagues and looking at all of the emails that they send us. They send us an email now for every patient that they send us, and we're going through all those emails and saying, should this patient have come to us, and now feeding back to them and saying, actually, this patient could have been managed in a much better healthcare resource if you'd sent them to, for example, an optician rather than the emergency department. And so the whole idea is about preventing people arriving at the front door. And everybody seems to be in agreement that Bradford is an outlier. 111 send us a much higher, 40% higher than any other service in the whole of the, as far as I'm aware, the whole of the north of England, send out 40% more patients than anybody else. Now, partly that's due to the lack of other resources in Bradford, in terms of we don't have an urgent care centre. Part of it is due to the fact that Accident and Emergency is the brand that they know, and it's centrally located and it's easy to get to. And we have never in the past turned people away. Well, now we are, but not in a bad way. In a nice way. We're meeting people directly at the front door and not waiting a long time and then being turned away. They've been met directly at the front door. They've been directly questioned. They're having their observations taken. We're making sure we're making safe decisions. And then we're sending them away with an explanation, and they're having their care taken care of that evening by a GP. And the response from the public from that has been, with one or two exceptions, absolutely, positive. And with those one or two exceptions, a little bit of explanation has, more or less turned things round about. So, we're quite proud of the work we've done with the CCG and with 111. It's not just been us, it's been led by all three services collaboratively, and it's something that we need to work on, need to continue to work on, but we are working with them.
Thanks, Dave. Thanks, Dave. That's a very thorough answer. Thank you very much indeed. I'll open up for any questions. Time for a couple, perhaps. Julie, I can see you've got your hand up. So if you want to unmute and come in with your question, Julie.
So just to reinforce Max's thanks from all of us. So we've seen the results of the work you've been doing, and we've been commenting on it for the last 6 months. We've seen the improvements. I think what's been really good this morning is listen to the how. How have you got there? And as a board member, that makes me proud too, the how you've done it. I'm pleased to see we're turning people away. I shouldn't be saying that as a board member, but I know it's been a last resort. And if we're doing that in an appropriate way, maybe we've got to the right time to do that. Has it lifted the staff, seeing the results? So has that lifted the team? Because I know for the team, we sit here and say how well they've done, but I know that's been a relentless slog and it's been really tough. Have the team been lifted then in seeing the results?
Thanks, Julie.
To be brutally honest, I think most of the team don't even look at the results. They just look at one another.
Yeah, yeah.
And the fact that people are in a better place than they were before, I think speaks volumes for our staff. The staff are not always interested in the metrics when it comes to ECS. They are very interested in complaints and learning from their mistakes. So that part, they are interested and do care. But I think the point I'm trying to get across is I think they care more about one another and the care they deliver as opposed to the numbers.
Yep, right.
I would say our recruitment and retention reflects that also.
Yeah, no.
Thank you. Do you mean the recruitment and retention is looking good?
Yes.
Yes, thank you. Yes, okay. Yeah. Thanks, Julie. Thank you. And just for colleagues around the room, Julie is the non-executive lead for the Finance and Performance Academy. So obviously she takes a keen interest, particularly in how the metrics are doing. So thank you very much, Julie. Brian and then Trudy, but I'll have to leave it at that then. We'll have to move on. So Brian and then Trudy. So Brian, you first, please.
Thanks, Chair. It was really an observation of where this CBU started from was a bit of a test bed for the clinical business unit model, because it started before we brought the rest of the CBU model into play. And I think what we as a board have seen is you've got to give it time, but you've got to have the right people. And I think what we've seen today is exactly that time and the right people with the right support. So this is about us as a board receiving information from the front line rather than historically we've sort of driven stuff from the board down to the front line. So when we worry about the CBU model and whether it's the right model, here's an example where it can work, and we need to build on that with the next iteration of the CBU structure. And I applaud, and I know Sam and I have had some very difficult conversations about how hard it's been. And I applaud him and the rest of the team who have made an enormous impact, not just the things they've done today, but they're pioneers for the whole organisation. And we need to build on that going forward. So thank you, really thank you.
Thank you very much, Brian. That's noted with pleasure. Trudy.
Thank you. And thank you very much. It was an inspiring presentation, extremely proud of what we've heard this morning. There were a couple of things that caught my interest in particular around what you've done, your work on the human factors, about pulling the leadership teams together and the involvement of occupational development, and also around the continual learning, and that you had the sharing of the learning. And I just wondered to what extent that was being captured, or your experiences could then be shared with other teams around the hospital.
So the newsletter is a brand new thing. The process before was we have the sort of split into cabinets, the planned and unplanned part, and we shared it at the quality and safety governance meeting at the unplanned part, because it's in the unplanned part of the organisation currently. But the newsletter, which Vicky Cox has put together, is new, and it's going to be a model that we're going to share. I'm going to share at the next quality and safety meeting we have as an unplanned cabinet. So that's quite new. With regards to our own CBU, we have SBAR's shared the acute medicine quality and safety meeting at sort of at the lower level that we share with all of our tiers, nurses and doctors, ACPs, healthcares, even our admin staff attend that. What we've learned is sending emails out about things doesn't work. You have to talk to people to get them to remember it, as well as present something that means something to people. And that's a difficult thing to get in a large organisation. So it's not a pilot, but it's a process that we're investigating to see how successful it's going to be. So, I mean, Vicky Cox she's an emergency medicine and paediatric emergency medicine consultant, very passionate about this, which has helped. So, giving her the time to do that has been a challenge, but she's now got it as part of a job plan that's sustainable, that will allow her to do it regularly. And we're already learning in acute medicine that we could probably incorporate it into the whole of CBU. So that's a first step. So I'll keep you posted.
Thank you. Is that okay, Trudy? Yeah, that's great. Sam, that's absolutely fantastic. Thank you. Thanks to all the team very much for your presentation. We note the comments in the chat box as well, and there's a nice comment about Saj, seeing you having come from Leeds here, Sam, so that's great to have you both with us here. So we note the comments in the chat box, and they form part of the minutes as well. I reckon the Board of Directors can officially endorse this CBU as our favourite now. given that you're the only one we've seen so far, I know. Okay, so fantastic work. Thank you very much for the input, and it's very much appreciated. It's been an eye-opener and an insight for us. So thanks, guys. Thanks to all the team. And I'll let you move on now to the rest of your working day. Thank you. Thanks, everybody. Yeah. I know I didn't name check everyone, but thank you, team. Yeah. Great. The quality of the content I thought was excellent there, and a real understanding, opportunity to question. So that could well be a model going forward. So thank you for whoever arranged that. I thought that was excellent. Thanks. John Prashad, do you know you've got a ghostly apparition right behind you? I'll take the nod as a yes. There you go. In fact, I will.
Yes, Max, it's on my wall.
It's called what?
It's on my wall.
Is it? Oh my goodness me! Yeah. It's a beauty, John. It's a beauty. Yeah. Just to let corporate governance know, I'm realising that I can't mute or unmute colleagues. So I don't know whether that's because we've got a couple of corporate governance co-hosts shown, but I'm unable to operate any of the microphones. So if you could have a look at that for me, please. Whenever I press the microphone button, it's showing as request sent. So I don't know whether that's something to do with my hosting authorities there, Jackie, but sometimes it's useful if I'm just trying to deal with feedback.
Yeah, I'll check Max and sort it.
Thanks, Jackie. That's great. Okay. Well, as I say, what a great start. That was excellent. I'm conscious, I know we've run on a little bit there, but that was well worth listening to and really useful. Mohammed, welcome. Good to have you on video. Thanks for joining us like that. That's great. Okay, so let's get on with the business of the meeting then. We've got our agenda. We'll run through, obviously, reports from myself and Mel when she's able to join us, which I don't think will be long now. We will review the risk register and integrated dashboard, and then we've got our sections under quality, which on this occasion include our maternity services update, of course, and I'll work to that as well, Karen. That's 9:55. Yes, you've got colleagues joining us there. 10:15. So yeah, then we've got the annual data protection officer report to note. Under finance and performance, we'll look at the dashboard, consider areas of strength and weakness, and look at our approved financial plan for the rest of the year. Workforce, we've got the people issues and healthcare worker flu vaccination, our assurance regarding that. And then in partnerships, we'll consider the role of partners at the moment and our latest strategy, people partners in place, and our work towards the next 5-year strategy that we've got there. We've got the report from the Audit and Assurance Committee, and we will return to the Board Assurance Framework and Risk Appetite Statement and consider that. With a couple of governance papers to note, which are safeguarding adults and children reports. They would normally have gone through Quality Committee or Academy, but they come straight to board on this occasion, which is fine. I was asked for authority for that. Some reports to note, which also include at the bottom there in the annexes the equality update and the res and des information that was required here. So does anybody bring any other items of business that I need to make time for, please? No? Okay, so if we can get through those agenda items, that'll be great. Okay. In total, of course, with the closed meeting, we've got till something like 1:45 today, haven't we? So we've got the majority of or all the morning. That's fine. So there'll be no other business. That's good to know. Are there any declarations of interest particularly to note? No? Okay, given that we now know the agenda. And are there any particular apologies for us to note? I don't think we've got any, have we? No, nobody's kind of looking at me or waving hands. So no, that's great. So we've got a full house of the board of directors. So that's smashing. Thanks very much. Just a reminder again, then, please, that this meeting's been recorded and will be published on the Trust's YouTube website by tomorrow. Okay, let's deal with the business from the previous board meeting. We have the minutes of the meeting of 10th of September. Could I ask whether there's any matters of accuracy and amendment to be noted there, please, or whether we can take them as a true record? So nobody's bringing to my attention any matters of inaccuracy or amendment required. So we'll take those as a true record. Thank you. And then with a number of actions, I'm going to assume that those shown action closed are approved, but I'll pause and make sure that that's the case. It's worth coming back to a couple of them. So those of you that got the actions up now, the second action is the equality update, the res and des submissions, so race equality and disability equality, and they have been added to the November agenda, thank you, at item 34. Okay, they also have been through Regulation and Assurance Committee as well, of course, so we have dealt with those at that committee. Thanks. We have the third action is shown as it arose from patient stories and relates to our patient discharge procedures. Now, although the action is closed, it does state that there's a verbal update to be provided under matters arising at this meeting. So the update helpfully tells us of the work that's being done and who's taking responsibility for top quality patient discharges. But the action note, Karen, just suggests there might have been something else you might want to say to board today. So I'll pass to you, Karen. So I'll just try and unmute you, Karen, see if it comes from here. No, they're all locked now, aren't they? I can't mute anybody.
Let me do it.
Yes, you're coming through. Yeah, you're coming through now, but everybody else is shown as locked. So a problem with the mutes. But anyway, we'll sort that out hopefully. Karen, you're coming through.
I think in the column we've answered 2 questions. So the bit MP advised national guidance is just around discharge in general and isn't necessarily linked to the point which was from the patient story, which was around the delays in giving medications to patients that are being discharged. So what we said we'd do, and we did, is start a QI project, and Sarah Buckley, who was on the call just before, started a mini test of change with one of the wards in the discharge lounge around getting medications, in a timely manner to patients.
Yes.
We started that and then had to stop because we closed the discharge lounge when we were dealing with surging demand and changing wards around. But what we have done just this week is started an additional project where we've got a HIT team of different professionals from different areas that are linking into 3 of the red wards to speed up on discharges and do things like make sure that the take-home drugs have been written, organise transport, that type of thing. So I think the action's closed. How we got there in the end changed because of COVID and dealing with the second wave.
Thank you very much indeed, Karen. That's understood. Thanks. Okay, I'm just moving through the actions. On action 22 is the NHS People Plan. I will just note at board and thank Selina for stepping up to be Health and Wellbeing Guardian as requested through the NHS People Plan. So Selina is our non-executive Health and Wellbeing Guardian. And no doubt at some time, Selina, you better tell us more about whether the role has brought you anything and how you're particularly shaping it. But thank you for that. And we know that you've offered to do that for us. Thank you. The estates and facilities and internal transformation, just worth noting that actually we should note Mark Holloway's apologies, Jackie, because Mark has sought permission to attend board through Mel, and that's been granted and unanimously agreed by non-exec directors. So although Mark is not an executive director, it's felt that the role and the importance of the department that he runs, the function that he runs, will actually enhance our board discussions. So Mark would normally be with us, but in fact, having intended to come, has had to give last-minute apologies, I think due to some form of estates meeting actually that relates to some building projects, so important enough to miss board. However, we do need to hear, of course, about the work that's being done in estate and facilities, and we note that the board development session on the 10th of December will offer us an opportunity for some deeper discussions about work with our colleagues in estate and facilities. So I did just want to bring that particular action to your attention as well. Okay, and the last action is obviously shown as a January timescale. So can I check whether, do colleagues agree that all those actions are satisfactorily managed and those closed can be considered as closed? Thank you. Okay, there's no objections to that. So we'll go straight to business reports. We have the report from the chairman. Clearly, with Mel not being with us yet, I'll move on from that and we'll get into other matters. But for the chairman's report, hopefully you've got the report in front of you and you've had the chance to see that. It's very encouraging to report that Council of Governor meetings have continued as they should. We've been able to move seamlessly to digital and continue to conduct those meetings virtually. And they were in front of the Board of Directors in terms of getting their meetings published. Obviously, the spirit of a Council of Governors meeting is a public meeting. And again, they are recorded and published on our YouTube site. Could I ask the Board of Directors to note at item 2 the sad farewell to two of our long-standing Governor colleagues, David Robertshaw and Hilary Meagan. Of course, they've been thanked in the usual way for their contribution to the Council of Governors. At the same point of number 2, I'll just bring to your attention that the Nominations and Remuneration Committee, so an important committee for the Board of Directors to be aware of, formally welcomes 2 new Governor members to that, Amit and Alistair, as shown in the documents. So I just ask you particularly to note that it's up to a full complement of members at the Nominations and Remunerations Committee. Our annual general meeting, which a lot of you have given feedback on, and thank you to those of you that could join the annual general meeting and annual members meeting. So given that it would have been nice to have held it face to face in the theatre with people present, that wasn't possible. However, we did, as you know, live stream that meeting. We've had, there were 70 members present during the course of the live stream, and we've had something like 500 views. So again, I compliment John and the corporate governance team for the work they've done there in terms of making us as transparent and publicly available as we can be under these particular times. So thanks for that. 2 further matters I think to raise from my report, still on that same item 2. Pauline Garnett, I just want to bring to the attention of board the superb work that our staff governor, Pauline Garnett, does for us as a member of the Board of Governors. So she is our representative on the Governor Advisory Council. Not every trust has one, so that there's just a limited number of governors go on the National Governor Advisory Council. And that for us is Pauline. And she takes that role pretty seriously. She represents us extremely well, including making presentations and writing up documents for circulation amongst other governors. So I just want to commend to you the work of Pauline Garnett, and I've mentioned in my report there the impact of coronavirus, a staff governor's reflection. Sadly, we note the impending departure in Trudy's case. So Trudy, thank you for your email, and we realise at the end of the year you'll be moving on from us, and we understand that it's reluctant, and we're sorry to see you go. And we also note that Laura Stroud, our medical school representative, has had to move on as well. Again, just to bring to your attention that in both Trudy and Laura's case, we are well underway in terms of replacement and recruitment. So we're on with that. And I'll finish by just bringing to your attention item 5, which is the fact that there is another joint session between non-executive directors and governors towards the end of January, 21st of January. And so again, could I encourage and thank non-exec directors for their good attendance at that meeting. And we know how useful a meeting that's proving. So that's something I'd want you to note. So unless there are any particular questions, I'll just bring in, I can see there's some chat things there. And so Mohammed, shall I go to you? And I'll also look for any other hands raised. So Mohammed, would you like to come in?
Thanks, Max. It was a really useful, report from the governors. A couple of quick things just to pick up on. Part of my information, actually, was the membership looks really good. And the narrative in there, how strong the membership is. But I was unclear what the membership was like in previous years. So was it growing, static, reducing? And then the other one I just wanted to pick up on was there's a table in there about membership numbers, and Keighley looks to be slightly underrepresented the way I read it. I just wanted to ask about that. And does that mean there's some work we can do around engaging with Keighley to try and drive up the membership for Keighley?
So, Mohammed, can I just bring to your attention that your microphone is not functioning correctly? I think I did get the gist of your questions. Were you asking about the size of the membership and whether we were underrepresented in the Keighley area? Is that right? Yeah, your microphone's not coming through at all. That's right. So, but that's okay. I think I've got that. Well, what I will say, I think we have 40-odd thousand members. So yeah, just some advice. It might be worth switching the video off, Mohammed. That could be the case for your microphone. So we have something like 40-odd thousand members, Mohammed. But of course, we're not efficiently in correspondence with that size of membership. We have an email list. Jackie, can I bring you in to remind me of the size of the email list, please, that we do regularly correspond with?
Yeah, we've got approximately 3,000 members on the email list, and it's mainly electronic communication that we are using at the present time. Yeah. So they receive my email updates, and we can contact them in real time to get further information. Now, we do have a working group, Jackie, don't we, that's intending to look at the membership and a plan to better engage a wider membership across the Foundation Trust. So we have that in place. Governors and exec colleagues will be part of that. Yeah, as part of COVID, some of that work has been suspended, but once Laura comes on board, which is next week, we'll be picking that up again and scheduling that in. I don't know if you want me to respond to the Keighley kind of question. Yeah, that would be helpful, Jackie. Thank you. Yeah. Number of members we've had there. Yeah. Historically, we've always had a lower number of members in Keighley, given, kind of the total population within that area. And primarily, a lot of that is to do with the fact that Airedale General Hospital sits within that area. So quite a lot of people are members of Airedale NHS Trust rather than Bradford teaching hospitals. I agree there are things that we could probably do to encourage more members within that area. And once we have the plan in place and we're developing the plan, part of that will be looking at how we recruit more members, or even, kind of look at ways of working with our other Foundation Trust organisations, Bradford District Care Trust and Airedale, to look at how we deal with membership. Jackie, that's really helpful additional information. Thanks. I can see Mohammed's put a note that there's some further information there. Jackie, perhaps we could weave a little more information about general membership for my next report, and in the hope that in the next couple of months we might have had a little bit of progress with that. So but thanks very much, and thank you for the question, Mohammed. It's an important point, and it strikes me that we've got a resource there, haven't we? 46,000, I think it is, members. That if there was some way indeed of engaging that size of a population, then there's some potential positive work from that. So, but thank you for that. Okay, I'll move on from that. Clearly, Mel, I don't think is with us yet, so it must be a very serious conversation with the regional director. And so in that case, I think we'll move to the quality section of our work.
Chair, sorry, it's John here. I think Mel was going to ask me to cover section 4. So if you're agreeable, I can do that, and then we don't need to loop back round afterwards.
That's really helpful. Thanks, John. So shall we go straight into the strategic risk register, please?
Yeah, of course. So since we suspended the Integrated Governance and Risk Committee, instead we now use one of the regular executive team meetings to have a good look at all of our strategic risks. The paper you have in front of you is a comprehensive list of all the open strategic risks. So I thought what might be helpful for me to do now, very briefly, I'm conscious of time, is just to play back the discussion we had in execs. And I think in future, what we ought to do is make sure the cover sheet accompanying this list of risks actually plays that out for you, so that rather than me having to give you a verbal account, it's just a summary of what we discussed. So roughly this is under 4 headings. First of all, execs reviewed all open risks. So there's an opportunity for execs there to talk about things they're responsible for or to comment on one another's. And the particular theme that we pulled out was a concern about the impact on staff due to the prolonged pressure of capacity due to the pandemic. So it was really just recognising there was a theme running through various strategic risks in relation to the pressure on our staff and managing that. We also looked at proposed escalations. So beneath the strategic risk register, there's a number of divisional risk registers. And we looked at proposals to escalate individual risks from those divisional registers up to the strategic risk register. There were 5 proposals. We accepted 3 of them in relation to staffing, quality of care, and FFP3 masks. But we decided 2 of them didn't warrant being on the strategic risk register. One of them was in relation to informatics, and the other was an operational issue. And the point to make here is, just because a risk is not escalated to the strategic register doesn't mean it's not looked at. It just means we haven't given it that particular focus of being on the strategic risk register. And if everything was on the strategic risk register, it would probably be unmanageable. It would just be too large. So we naturally use divisional risk registers to manage a lot of the material. We then looked at a movements log, so that helps us understand new risks entering the strategic risk register for the first time, or risks which have changed in score, either gone up or gone down, or indeed risks which have been closed. There was one new risk, and that's 3598. That was about children and young people who've been admitted to the acute hospital, but with mental health crisis. And it was about whether we've got appropriate processes, protocols, procedures in place to help manage those circumstances, for example, around physical restraint. And then there were 5 existing risks where the score had changed. And so we wanted to bring those to the attention of execs, just have some discussion, because it's important, obviously, we calibrate the risks one against the other, and we don't have one being massively escalated when in fact there's something else in a different part of the register that might be more appropriate. So we had 5 risks changed in score. Number 3380, which is about patients with a mental health diagnosis being treated appropriately and whether staff have the relevant knowledge and awareness. That risk increased in score. We thought there was a greater likelihood that the circumstances might arise, so we needed to strengthen the mitigations around that. 3351 was about monitoring and control of COVID-19, and we thought the risk there of the potential risk of harm as a result of our ability to monitor and control CV-19 had increased, the likelihood increased, and that's fairly obvious due to the increased number of cases and the greater population risk. 3554, which is about cash and liquidity, and 3555, which is about financial stability. Both of those increased in score from a 6 to a 9, so still by no means the highest risks, and I think that's more about recognising where we are in the year, in the cycle of finances and so on. And then finally, risk number 3560 is about safe staffing, and in particular, the potential impact of test, trace and isolate. So if we've got large numbers of staff who are being contacted as a result of having been in contact with someone and being told to isolate for a fortnight, there's a significant risk there for us of a staffing pressure. So recognising that we're in the middle of a second wave and people are being exposed to the virus and there's a risk of being contacted and having to isolate, we increase the likelihood of that risk from an 8 to a 12. And execs noted all of those changes in score and didn't disagree with any of them, felt they were appropriate and proportionate. And the final item we discussed in the exec team was a specific set of risks around partnerships, where we have had historically some risks around acute provider collaboration, so the partnership collaboration with Airedale Foundation Trust, and some of the risk there was about understanding the nature of the collaboration and existing services, and some of it was about not getting the right scope or being able to effect the right change. And really, the acute provider collaboration programme has now been subsumed within Actors 1, and it no longer felt appropriate to have an entirely discrete risk about acute provider collaboration. There was also a risk for partnerships in relation to the creation of 2 arterial vascular centres and the risks of delay in a decision being ratified by the centre. Well, of course, as we know, that decision has now been ratified, and we're actually into implementation phase, which is being taken forward by operation and clinical colleagues. So we've made some changes there. We've closed some of those risks down, and we're doing a fresh risk assessment on the, if you like, the horizontal integration, the work across West Yorkshire and the integrated care system. And so we're doing that assessment, and it may be we bring back a new risk to the strategic risk register, but at this stage, that's not something we've agreed. So that was the discussion we had amongst execs. Some of those changes will have fed through to the strategic risk register, but not the proposed escalations. I talked about 3 new escalations. They won't have fed through yet. Everything else is reflected in the risk register in front of you. So I'll just pause there for a moment in case there's any queries on that. The likelihood is if you've got a question about a strategic risk, probably the best person to respond to it will be the relevant exec, rather than me providing an overview of how we've managed the register.
Yeah. Thanks very much, John. Karen, can I just come to you and ask whether you wanted to add any additional information regarding the staffing risk mentioned?
Yes, thanks, Max. I noted, I think it's a timing issue because we talked about these risks at execs, I think it's like the 2nd of November. And John rightly mentioned the risks around staffing and the FFP3 mask that we've escalated, but they've not found themselves onto the printout, and it'll just be the button hasn't been pressed after the meeting. So, but I think it is really important. So there were currently 2 nurse staffing risks that sat on my chief nurse risk register. One was about staffing levels and the impact on patient safety. One was about staffing levels and the impact on the staff themselves and their health and well-being. I've reviewed all of these risks with the teams. I've reviewed them regularly, but we feel that because we have stretched our staff even further, we are working to just safe staffing levels that are not necessarily NICE recommended staffing levels. We've had a couple of internal whistleblowers through Freedom to Speak Up about nurse staffing when we've opened wards at short notice and asked staff to move. We've now had contact from the CQC, so we've had an external whistleblower to the CQC as well around nurse staffing in relation to opening Ward 11 last week or the week before. So we have now raised both of those risks to a risk of 20. So this is the potential. So one is around the potential for impact of suboptimal care, patient safety issues associated with nurse staffing. The second one is the impact on the staff themselves. Now, I'm sure Pat will comment at some point as well when she talks about staff health and wellbeing, but we are seeing staff, and Sam Khan also mentioned this, extremely tearful at times, upset, worried, concerned as we've moved into the second stage of the pandemic. So there are 2 real risks that we are mitigating and monitoring on an hourly basis. So we've got dynamic quality and safety tools that we test. We put additional cover on of senior nurses 7 days a week, 24/7. So everything is being done to mitigate, but sadly, we are seeing an increase in pressure ulcers. Some of that is related to NIV devices. We are seeing an increase in, slight increase in falls, but we're definitely seeing an increase in sort of low-level concerns being raised by staff. So I wouldn't want board to think that this is easy or a walk in the park. It's extremely difficult for our staff at the moment, but we are keeping people safe, and that's the key take home.
I was just going to ask you to emphasise that if it was the case, Karen, that despite the challenges, would you tell us that you are maintaining safe levels of staffing?
We are maintaining patient safety. The levels of staffing are safe. They are not what I would want them to be or anyone would want them to be. Okay. But I believe that the systems and processes that we have in place are excellent, actually. The way we manage the command centre with senior nurses linking into that 7 days a week and the site we have gives me the reassurance that we can respond very quickly. The problem is it is such a moving feast. So I was on call just this weekend. You think you have a staffing plan for the wards on Saturday morning, and then a couple of staff get contacted by Test and Trace, somebody else becomes unwell, and you're suddenly 4, 5, 6 staff members down, which has a real impact.
Yeah. Okay, noted with thanks, Karen, yeah. John Prashar, you have a hand raised. Did you want to come in, John?
Yeah, thanks, Max.
Yeah.
It really relates partly to what John said about the mental health risk and the increase in potential and the mitigation, and it probably relates to some stuff Karen said. My question was principally around, in terms of identifying that mental health risk, how much of that detail is about people trying to live their lives with COVID generally and having increased mental health concerns, and how much of it relates to the likely experiences they have actually in the hospital, so changes in visiting, isolation, food issues. I just wonder how much of it is general life and how much of it is actually care related, if you can expand a bit more. Thanks. Thank you, John. I think Karen has some information on that, yeah.
Thanks. There's 2 risks in relation to mental health. One is a new one, one's an escalated risk. So the escalated risk is around adult patients with mental health issues. So they're coming for a physical reason, but have a mental health related issue as well. We know that, and it's a generalised thing, that because patients aren't having face-to-face contacts with mental health services in the same way pre-COVID, we are seeing a deterioration in when patients with existing mental health conditions, long-term mental health conditions, are attending, they are more mentally unwell than we would normally have to deal with. So we're dealing with some incredibly unwell patients. So it's not necessarily around isolation in hospital or us causing a deterioration in their mental health whilst in hospital. It is people living with mental illness that are coming in with physical reasons. So that's one of the risks. The other risk is around children with mental health, and this is something that's been going on for many years. The placement, specialist placements that are available for these children are very hard to come by. They often are 200-300 miles away from home. We are seeing increasing numbers of children that we're unable to place quickly, and we're deteriorating quite difficult behaviours to manage when they're inpatient. So that's the 2 risks there.
Thank you, that's really helpful, Karen, thanks. Barry, can I come to you now? I know you did inform me prior to the meeting, you had some queries about the Strategic Risk Register. Does this remain the best forum to deal with that, or would you need to spend more time at the Regulation Committee, perhaps?
I'd like to suggest a mixed approach. There are 3 points that I'd like to raise here, and a number of others which I suggest I send emails to the relevant exec director.
Thank you.
Perhaps copying the other non-execs, and then we can pick up on those in the Reg Committee if appropriate.
That's perfect. That's helpful, Barry. Yeah. Thank you. Go ahead then. Yeah.
But for now, there are just 3 that I'd like to refer to. Risk 3380, John referred, well, both Johns have referred to it. This is the mental health staffing issue. Note the increased current risk rating of extreme. Good to know that we've got a mental health nurse coming on board to further focus on this. Just reading it, I wondered whether one mental health nurse was a sufficient attack on this risk.
Karen, please come in, yeah.
Yeah, we don't just have one mental health nurse, so it's an additional mental health nurse. So Sarah Turner, who you will be familiar with as the Safeguarding Adults Lead, is a mental health nurse by background. Another member of her team is also a mental health nurse. This is a bespoke post that we've funded as an organisation for a pure mental health nurse, just to focus on people with mental health issues. In combination with that, because mental health isn't our core business as such, we have links with the Care Trust. They provide a psychiatric liaison service. In addition to that, on the back of a serious incident that we declared a couple of weeks ago, myself and Brian met with colleagues at the Care Trust, and Paul Southern is in conversations at the moment with how we make sort of video consultations with the psychiatrist of the day, so that our staff can get very quick consultant psychiatrist information and consultations for our patients. So it's not just one mental health nurse, there's a team around it. That's an additional post that we've put in, Barry.
Okay, thanks for that. Second point, a risk which I've raised a couple of times before, 3468, which is on page 7 of this strategic register, which is now flagged for Sarge, understandably, rather than Sandra. I guess every time I read this risk, it just concerns me that we're saying that incorrect information could lead to incorrect decisions about patient care. I just wonder if we're doing enough fast enough to address this particular risk.
Just assist there, Barry. Is it the one, a risk that patients may come to diagnostic pathway with endoscopy? Yeah. Is it the endoscopy risk you're referring to?
No. This is difficult to read these things, isn't it? 3468, which is the top of page 7.
Sorry, 8. I'm reading the wrong one. Okay, Mel, I can see you wanted to come in there. Yeah. Would you just remind us what that risk is? Can we see the text of the risk so that colleagues know exactly which we're talking about? Are you able to do that, or can anybody else do that?
I can do that, Matt.
Yeah, what is the risk, please?
It is a risk that staff aren't being able to follow the correct processes for recording activity because data quality issues on the EPR system, where we can end up with duplicate patients on there. So that's what this risk attains to, really.
Thanks, Saj. Thanks. So, Mel, I can see you would like to come in on that one. So, yeah, thank you.
Thanks, Chair, and apologies for being late. I was on a regional call. Colleagues will appreciate that Sandra, who was the exec lead for this, who has now retired and has taken some leave, is due to return to us soon to take on responsibilities of Deputy Chief Exec on a part-time basis, but also the lead for certain special projects and very kind of clearly defined projects. One of those projects is the issue that Sarge has just alluded to. So we will have some dedicated time from Sandra in her new role for the next 6 months, and we will be able to put more effort and energy and focus into addressing this specific risk.
Thank you, Mel. Thanks. So, Barry, there is some attention to be paid to that particular.
Okay.
Yeah.
Okay. The final one, and this is perhaps a little early to raise, but I was prompted by risk 3560. It's actually only prompted by that rather than wanting to focus on it. It's always fascinated me the proportion of healthcare professionals who refuse to have flu jabs. With the very recent news about a COVID vaccine, I just wonder what the staff reaction will be to the availability of the vaccine and what our stance should be as a board in terms of our duty of care to patients and to staff. How will we approach this if members of staff are reluctant or refuse to take the vaccine?
Should we invite comments on that as we take the paper on the flu vaccine, perhaps? Yeah. Okay. Pick up on that later. Pat, is that okay? Would you note that, and perhaps we have a paper on flu vaccination best practice, so perhaps we could develop into a discussion about any future COVID vaccine there. Yeah. Is that okay, Barry?
That's fine.
Yeah. No, thank you, and your points are well noted. And little more to do at regulation committee as well, or in correspondence beforehand. Thank you. John, I'll come back to you. It's apparent from the notes in the chat boxes, John Holden. So firstly, thank you for people for the contribution to the chat and for those that have been able to respond to queries on there. Again, we will integrate any chat comments into the minutes of the meeting. And John, obviously your offer to look again at the cover sheet and an easier analysis perhaps for colleagues to digest quickly would be well received.
Yeah, thanks, Max. Mel made exactly the same point to me this morning, so I'm bound to agree. I think it's been a really helpful discussion, and I think we'll certainly make sure we repeat this next time. But I'll make sure it's in the cover sheet so we can then get straight to the meat of the issue. That was very helpful.
Thanks,
Max, I'm conscious that colleagues have joined us ready for the item on maternity services. And I think in respect of the next item, integrated dashboard, I would say the same as we always say. This is a balanced scorecard. It gives you an overview of different areas, but we're going to talk about those individual areas anyway when we go through quality and people and so on. So I don't think we need to say any more at this point. And if colleagues are happy to leave it there, there'll be things about the presentation of the dashboard we can talk about, but in terms of the detail, we'll cover it anyway as we go through each topic.
Agreed, John. And what I'll do is I've made a note for myself to come back to the integrated dashboard as we've gone through the different areas. So an opportunity to return to that. So, okay. Board colleagues, can I ask you whether you are sufficiently assured of the exec oversight in relation to strategic risks and that they have been maintained during the response to the pandemic? Can I ask that we endorse that? Yeah. I realise there are still matters to be dealt with and with stronger and weaker areas, etc. But thank you. Okay. That's all noted. Thanks. We will move to quality now. I'll warmly welcome our colleagues from maternity who are here to assist with the presentation on taking our maternity services to outstanding. So again, Karen, I'll perhaps leave it to you to make the introductions. Ideally, I would have liked to have just focused on the quality dashboard before beginning, but given that people have joined us on time and we can get on with hearing about maternity issues now, let's do that, and then we'll return to key quality issues. Obviously, any quality issues that arise in maternity will be drawn out by this discussion. So, Karen, shall I pass to you, please, to introduce the team and to bring to our attention the update which we have had. The PowerPoint came round last night, thanks, regarding maternity services update and taking us to outstanding.
Thank you, Chair. So to be clear, this is an update on the OMS programme. Specific quality issues and or dashboard issues with maternity, we usually pick up in Regulation Committee with some specific actions within our trust or oversight dashboard. So I wouldn't want to distract from the fantastic work that the team are doing to move to outstanding by going into the detail of some of the action plan stuff, because I really want the team to get across the fantastic work they've done over the last few months, where they've met with external and internal stakeholders. Some of you guys have been involved in that as well, to really firm up what an outstanding service looks like for us and what our vision is around that. So present on the call, we should have Sarah, who's head of midwifery, you'll know really well, Carolyn, who's the director, Kate Lavery, who's our PMO support, Debbie Horner, who is here as, she's a consultant anaesthetist, but is providing some strategic and oversight into this as well, and also Hannah, who is the CBU manager. So I'll hand over to these guys. They've got some great messages to pass on. I'll leave them in their hands.
And welcome all of you. Thank you very much for joining us at board. Appreciated.
Good morning, all. Thank you very much for inviting us all to come and speak with you this morning. So I'm just very briefly going to make an introduction. This bit we're going to keep brief. You all are aware of the OMS project, so we're just going to let you know more about what's been happening since the launch. So the OMS is a large-scale project that was approved at board in the spring of this year. It sees us bringing lots of people together, thoughts together, and people's drive to to really focus on everything that that we do well in the CBU and things that we need to build on to improve to get to where we really want to be. One of the key focuses, well, the main focus of the project is to really keep the woman and her family and her baby at the heart of everything we do, and that's a key thread through all of the work streams. The OMS project aims to look at the quality aspects to really drive to outstanding, and to weave into that the necessary changes we need to make to that were identified in the recent CQC inspection that was in November of last year. So in order to bring this project together, we had a launch event. What we really wanted to do was to focus on our staff and what their thoughts were. So the work streams were really driven from that launch event. So that's where we started. We spoke with the staff, and all of those work streams were born from that launch event. We were very fortunate in the middle of the pandemic to be able to have a face-to-face launch event to really have some of those breakout sessions so we could listen to our staff. And from that launch event, the 5 work streams were born. So they were investing in our workforce, a building fit for the future, the women's journey in clinical excellence.
Oh. You're muted, Hannah. Thanks, Hannah. You just went muted just for the last couple of sentences there. So.
Oh, did I? I'm sorry. I panicked and I've been muted for the whole thing. Sorry, just.
It's okay. We can hear you clearly. Yeah.
Thank you. So following the launch event, which saw many of the faces on the call this morning able to join us, as well as external stakeholders, our staff, we've managed to pull the work streams together. And within the maternity building, we've developed an OMS hub, which is a workspace that allows people to come and to join us and to share their ideas of things that they want to lead on, things that they want to improve, and to allow access to the team, the OMS team, the project team, as well as the triumvirate. We've developed workstream leads for all the 5 work streams that I've highlighted, both medical and midwifery. We've developed a vision document, as well as we've produced charters for each of the 5 work streams, and they've been presented last month to the OMS board. So now I'm going to hand over to Alison Powell, who's just going to briefly take you through the work that's beginning to happen and some of the objectives from each of the 5 work streams.
Thanks, Hannah.
Thank you.
Alison, shall I unmute you? I'm afraid I can't. So, Alison, you would have to unmute yourself. For some reason, I'm not able to mute or unmute here.
Max, you might want to ask Sarah to step in for this bit if we can't get Alison.
Yeah. Like I say, normally I can unmute, but when I try to do that now, it's showing request sent. So I'm not sure why we've got different settings today on this. And I don't like not having that power cab, you know that, don't you? So you can obviously hear me okay anyway. So Alison, if you can hear me, can you unmute and join us? And if you're not able to, I'll maybe...
I can step in if you like. If we appear to have lost Alison. If she pops back up again, I'll pass back over to her. So in the slide pack that you received yesterday evening, I think I think this is one of our great successes of the project so far. You know, the development of the project charters for all of the work streams. So without going into too much detail, because you've actually got those things in front of you, I think it's just worth having a quick look at those. We've starting with stuff like the woman's journey and that strive for clinical excellence. We've now actually been able to really work through where we are at the moment, where we want to be next, and actually what we need to do to achieve that progress. And I think more importantly, we've now agreed on some real measures that will help us to understand whether we're actually meeting our own objectives. So, for example, with the woman's journey, our measures will be things like looking at, have we seen that reduction in our stillbirth rate? Are our waiting times in antenatal clinic improving? Are we getting that feedback from women to say that they're actually noticing a difference in our services and how we're presenting things? So the next one is the investing in our workforce, and again, following exactly the same layout where we are at the moment, where we want to be, what we plan to do next, and again, the measures. So I think one of the great things there is that we're really trying to focus on that workforce modelling and actually really developing our staff with training opportunities, and I think that undercurrent of developing a culture that's based on kindness and support. And I think that's come from our staff. They've identified that as a need, and that's something that we're really going to focus on. Again, measures to go alongside that. I think all importantly, the staff survey. I have received something from Pat this week to say that maternity haven't been great at responding to the survey this time round. So we really need to be pushing that for this year. But would really hope that if we're successful with this element of the work streams, that actually people will be really happy to just fill that survey in immediately next year when it comes round, because we'll be in a very different place. Next one along is the moving to digital. Again, the where we are now, what we want to do next. We're obviously really focusing on that move to Cerner maternity. There's a lot of work being done there at the moment, and again the measures that go alongside that, and then streamlining systems. Sorry, I'm having to look at two screens at the moment. It's quite distracting. So the streamlining systems. Again, what we've sort of noted at the moment is that we've got quite a lack of data cleansing, and we've got quite a lot of variation in how we're presenting our data. And sometimes it has come across that we've not known some of our problems, and I think that is one of the underpinning themes that we have here. Sometimes it's because of how things are collected in various parts that we don't always have a handle on. So there's a real strong piece of work going on there to make sure that we absolutely know and understand our own data before we are able to sort of share it more widely. There's a huge piece of work with governance there, and Nada and Carly are leading on that. And then I think another real biggie for us is the building fit for the future. I think that's one of the key things that came out of the work with staff during the engagement, the engagement piece of work. We're sort of at the point now where we've outgrown our unit. It's a little bit too small in some areas for women, families, and staff. And we really need to look at what we need to do to run our services effectively from the estate that we have at the moment. So there are obviously some things that are already well underway there. So we have, for example, the theatre project is already underway, but does fit into that piece of work. We have also really importantly engaged with our Maternity Voices partnership on this as well. And we're about to start a 15 steps piece of work. So, because one of the things we have is that the first impressions of the unit, it's a little bit unwelcoming in some areas. So we're actually going to bring some of our service users in, whether that's virtually or whether we can manage to get people in the unit to do that 15 steps piece of work, which we've not done here before. I think that's the bit where I hand over to Carolyn. You've caught me a little bit off guard, as you see, because Alison was supposed to be talking to this bit.
Well done.
Carolyn, are you okay to step in next?
Thanks very much, Sarah. Good morning, everybody. I'm Carolyn Roberts from the CD for Women CBU. I'll just take over from Sarah now, just to tell you a little bit about some of the achievements that we've made to date with this project so far. And I think we've achieved quite a lot in quite a short space of time. As we've already sort of alluded to, we really engage with not just our local staff and patients, but also external stakeholders that actually came to our engagement event, which was brilliant to get their opinions, both from sort of a primary care approach with our GP colleagues, the CCG, and also, as Sarah's just touched on, the Maternity Voices Partnership were present, and they've done some brilliant surveys and work through COVID with some of our patients, really trying to understand about patient experience during that time. They've already started work on the 15 steps, looking at all the clinical areas, both obstetric and neonatal, looking at, as a patient walks in, how does that feel? What's the environment like? What's the signage like? And actually how that affects somebody's experience and their opinion of the unit to giving great care. The Maternity Voices Partnership have also currently involved in co-designing our visiting guidance, again, really linking with those women and the families to sort of really achieve what they feel is what they want for their birth experience. The survey that the MVP did during COVID really sort of was a great way of understanding what the needs of the women were locally. And as a result of that, they've been involved in trying to make sure that we get information out there to encourage women to visit the unit despite COVID, for instance, with reduced fetal movements. That's a key area that we really talk to women about a lot, but to get the Maternity Voices Partnership involved, speaking to women locally about the importance of reduced fetal movements and reporting those could really have effects on reducing our stillbirth rate and working there. I think we've done some great work in communicating with our staff of all areas about what's going on, what stage we're up to, and how the project's getting on. And we've been almost overwhelmed with the volume of staff that want to be involved, either in a very small capacity or in a greater capacity and, say, leading on these work streams. We've got midwifery and medical leads on each of those 5 work streams that have been described so far, so that we get both a midwifery and a medical perspective. We want to make sure that we're collaborative in our approach. We want to make sure that we link in with the Better Births project across the region and make sure that certain areas of work, for instance, perinatal mental health, it won't just benefit us to get it right, but we need to think about the wider area and the region about how we improve certain services. We want to make sure that any existing work that's going on in the unit is linked with the OMS, so we don't lose sight of projects that are already ongoing. And we've done really well in some of the project planning, the timelines, and meeting those deadlines that we had for ourselves. In terms of risks, though, there are some things we've got to touch on. We can't obviously ignore COVID at the moment. It might have an impact in terms of the availability of certain staff that are involved in some of those leadership roles and getting involved in projects, particularly if they're called away to clinical areas to look after patients. So that's just something that we need to bear in mind as we move forward, but we're going to do our best to make sure that this runs as best as we can. We think there's going to be a significant investment required to get the building right and fit for purpose, whether that's reconfiguration, whether that's a slightly bigger building, and looking at certainly our ambulatory areas on the ground floor is a fairly urgent priority. In terms of things that you can help with, we've got key areas that we know we're going to need help from other areas of the hospital to make it happen, such as we're going to need help from estates to look at these redesign, how we reconfigure the building, what works might be required. We're certainly going to need help from HR, looking at workforce, how we remodel some of our rotas and how we use our workforce and different ways of working. And also, I think there's quite a big piece that we need to do about culture within the unit and how we make sure that there's a real move to outstanding in the way we move forward. In the presentation at the very end, once you have a look, we've got a thank you card that we're going to use widely and make sure that we recognise people's input and investment in this project and thank them for their time and investment in it, which is just listed at the end there so that you can see it. Thank you for the opportunity for listening this morning, and we'll take any questions now.
That's smashing. Thanks very much, Carolyn and Hannah and Sarah for stepping in there. Alison, we understand the problem you had with your tech there, so absolutely no problem at all. Hannah, can I just ask you to answer a couple of very brief questions, please? Could you just let me know what the OMS board actually looks like? Who sits on that? How often it meets?
So we meet monthly. Karen is our exec sponsor, so she chairs that meeting. James Taylor, as the Director of Operations for Plant Care, is the Senior Responsible Officer for the programme, so he's there. There's all of the team that are on the call this morning, Debbie, Alison, Kate, our Programme Manager, and then we have our external to the CBU stakeholders, so neonatal anaesthetic representation, honestly, Debbie's helps bridge that gap as well. And then external partnerships, so MVP, and we have colleagues from the CCG as well. So it's a very big board. It's often it's a very productive meeting as well. So it's not just a straight reporting up meeting. It's we get to chat to all of our external stakeholders in that. So
that's great. That gives me some insight. Thanks very much. Okay, so I can see that Selina and Trudy would both like to come in. So if I could start with Selina, and then we'll go to Trudy for questions. So Selina first. Are you able to unmute, Selina?
Can you hear me now?
Yes, you're coming through now, Selina. Yeah. Did you have to respond to a request from me there, or were you able to unmute yourself?
It says a box came up which says unmute me. So there's like a special message came up.
Yeah. On my settings, I've got allow attendees to unmute themselves, and that is ticked. So colleagues should be able to unmute. I don't know what's happening there, but anyway, we can hear you clearly, Selina. Yeah.
Good. Hannah, thank you for your presentation. I was just wondering, given the issues are mainly related to South Asian women, how do we get the views of South Asian women incorporated into all the planning and evaluation of the work that you're doing? And that's from service users themselves, but from a professional perspective, what's the makeup of the teams who are on the board or individuals on the board in terms of ethnicity?
Max, can I ask that question's redirected to Alison or Sarah as the midwifery clinicians, because I think they're best to plan for that.
Sure. I think Sarah may have unmuted to try and deal with that. Yeah.
Yeah, I've got Alison with me now, so yeah. Do you want to take that one, Alison?
Yeah, so I can respond in terms of engaging with our service users and ensuring that we reach various groups of women. And when we had the launch event, what was really precious was the involvement with the MVP, and their feedback on the launch event was that they had managed to reach women from all postcode areas and all both ethnic groups, but also from an enable point of view, women with disabilities and other particular needs from those often hard to reach voices. So that was really important for our launch event, for the presentation, to actually have the voice of a variety of women brought to the room via the MVP. And that relationship and that working partnership we've got with them going forward, that is one of our key values that they're aware of, that we want to make sure that we can hear the voices of all women, and in particular often the unheard or less heard voices. Do you want to answer the board representation?
Yeah, I think from a staff perspective, Selina, the launch event was well attended and was very representative of our staff population as well. I think the work streams as they're starting to unfold will reveal sort of staff who are from different ethnic backgrounds who will sort of self-volunteer. And I think we've already done quite a little bit of that work. So Alison and Kate in the PMO hub have been inundated with people knocking on the doors, coming forward with their ideas, and that does seem to be very representative of all staff from all backgrounds. So that's just something that we are obviously really trying to bear in mind, and we'll continue to build on as the work progresses. But we've had people coming forward, you know, from sort of junior band fives right up to more senior members of staff who are coming with some really great ideas, because they're the ones that are doing the work, and that, you know, they can see where the changes need to be made, and there's sort of no discrimination there whatsoever. It's anybody can come forward with an idea and will be absolutely listened to and valued. And I think if you look on the bottom of the on the presentation, it does give you a bit of a breakdown of actually who's leading on those as the work stream leads in each of those particular key areas.
Okay, thank you.
Does that help, Selina? Yeah, thank you.
Yes, it does.
Thank you. Thanks, Sarah. And Trudy, would you like to come in? Yeah, you are unmuted, I can see.
Yes, I am. Yeah, thank you. First of all, just wanted to thank the team. Their ongoing energy and enthusiasm, which was very much there and apparent at the OMS launch, but clearly is still in full flow, and that's great. And I very much like the responsiveness that I see in the programme that you've put together with the 5 work streams, responding to comments that I also was hearing on the day from staff and other stakeholders. So I think that's a very good reflection. I agreed with the comment made during the presentation about needing the help and assistance from other teams around the trust. And one area I wanted to flag under the work stream for investing in the workforce, we had a presentation earlier from the urgent care team, and there was some work which they had done, successful improvements they brought about in terms of pulling together and integrating across the leadership and training together, and I just wanted to mention that it also resonated with me in terms of some of the comments I picked up on the day at the OMS launch, and just interested to hear about your reaching out to other teams.
Deborah, would you like to come in on that? Yeah, thank you.
So one of the things that we've been a front runner in really in the region is some of our work around maternal critical care, but also some of our simulation work. And some of you might recall that we won Team of the Year for simulation a couple of years ago. And that was for a simulation that we did on ICU for a lady that needed a cesarean section following cardiac arrest. That involved the ICU team, the neonatal team, midwifery, obstetrics. We've also run that same scenario in A&E. So I do think that we've made some good kind of progress in terms of that reaching out and training together. So I think a lot of the time we talk about training together just within the midwifery unit. We've actually already gone beyond that and spread ourselves into the main site too. So hopefully we'll be able to continue with that work.
Does that help, Trudy?
Yes, no, that's very interesting to hear, and I'm aware of that. But my question was more about within sort of neonatal midwifery, pulling the teams that work more closely together. But it's fantastic that there's also wider reach. Thank you.
Caroline, did you have a comment on that?
Yeah, I just wanted to say, you know, a lot of these projects, we do touch certain specialties, particularly anaesthetics and our neonatal colleagues extremely regularly, and they are really keen to be involved as well. We've got, again, various volunteers to be involved and have representation so that we hear what their concerns are and see how we can work and improve our links with them. Certainly only yesterday we had a joint neonatal obstetric governance meeting, and actually I've just reflected with one of the neonatologists this morning, and it's a really valuable link to make sure that our outcomes, i.e. mum and baby at the very end of all of this, are the best we can achieve. So I think those links are there. I think it's just how we plan moving forward to actually involve them regularly.
Thank you.
Thank you. Thanks, Caroline. There's no further hands raised, but I just had one question, perhaps either for Sarah or for Hannah, which was that earlier today we heard from Urgency and Emergency Care CBU and the work they were doing on Schwartz rounds and the psychologically informed working environment, working with psychology services. Now, I've heard about culture and supporting staff from yourselves, and I just wondered whether you considered, or indeed if you were doing that sort of work.
So Max, we have the advantage in maternity that we have PMAs, professional midwifery advocates. So we're using the PMA process to provide some of that support to staff, and have extended that. That doesn't just have to be midwifery restricted. And then I think really our own goal is that obviously we've got Virginia Beckett within our CBU, who is is one of the leaders with the Schwartz round. So again, it's possibly something that we've not considered in great detail yet, but absolutely. I think it's also really worth mentioning that certainly over the last few weeks, when we've seen an increase in sick women needing intensive care, we've also used the trust psychology team to actually support some members of the staff, members of the team that we wouldn't automatically think of. So our research midwives have been very involved with those women, and we've just made sure that we're sort of trying to align that, and that everybody's getting the relevant psychological support that they need as well during this difficult time. Just going back to the previous question, though, really quickly, I'd also just like to say that yes, whilst we're also engaging with our neonatal teams and anaesthetic colleagues, what we're also trying to use the OMS programme for is that this is a great opportunity for the collaborative work that we've established with Airedale. So we're just we're trying to make sure that we're working on representation between us and a member of the Airedale team, either at our board or certainly within some of the work streams, so that as we're trying to develop and redesign some of our pathways, we've got that joined up piece of work between the two. So apologies, I just wanted to get that in before I forgot.
Thanks very much, Sarah. That's great. So another excellent input from the team. Thank you very much indeed. It's so encouraging to see progress as it is. Great opportunity for people to ask questions and to understand more of what's going on. Should Karen, maybe come back to yourself as the exec lead and ask whether you'd like to just roll things up? Any points you wish to bring to our attention at board?
So I'd like to give my personal thanks to all of the maternity team and the extended team, so everybody that's been involved in this. And just to stress that for the maternity team to have carried on with strategic piece of work that they've been doing, whilst dealing with everything else, is nothing short of a miracle. Because people might think that COVID doesn't impact on maternity services, but it absolutely has, and it absolutely does. So the staff have been dealing with COVID, working in very different ways, working in enhanced PPE, splitting the unit to care for women, dealing with increasing numbers of women and increasing calls, dealing with the workforce issues that everybody else has dealt with as well. Also, they have over the last 12 months significantly improved many of the safety measures that we've been tracking throughout the maternity services. So the one-to-one score in labour we know is consistently 90% and above now. And then they've come up with this great piece of work which really talks about where they want to go with clearly defined smart objectives. So they've condensed a huge amount of information into one place, and I think they've done an outstanding job, and I have no doubt that they will become an outstanding maternity service.
Thanks very much, Karen. Well, the entire board of directors support that and want to do everything we can to help that happen. Do you remember we're the UK's youngest city? Why would we not want an outstanding maternity services in the UK's youngest city? Very, very important to us. So thanks, team. Please keep going, and thank you for giving us your time today to better understand the challenges and the work you're doing. So thanks very much, and I'll let the maternity team leave us now with the sincere thanks of the board.
Max, can I just interrupt really, really quickly? Our very glossy Journey to Outstanding Vision document has now been produced, and members of the board and people who are on the call will receive a hard copy of this to have a look at.
We promise to read it thoroughly. Thank you. Yeah, that's great. Thanks, team. Thank you very much indeed. Wonderful. I'm conscious Jenny has joined us. She was on time and we weren't. And Jenny is our Data Protection Officer and is going to present the annual Data Protection Officer report, which is for us to note. So what I'm thinking is, should we take Jenny's report, ask Brian and Karen to perhaps reflect on any key quality issues that emerge in the dashboard, and then just take a 5-minute break before getting on with the rest of this morning's business, yeah? So should we try and do that? I'm conscious Mel's joined us as well and will want to give us a briefing, but let's put that into after the break there. So if we can go to Jenny, and then we'll ask Brian and Karen to focus on key issues arising from in relation to quality. So Jenny, welcome. And Karen, again, I don't know if you want to start this bit off? Happy to go straight to Jenny? Yeah. So we've received your report, Jenny, and we're being asked to note it. Is there anything you'd like to bring to board's attention?
Hi, good morning, everybody. Just a few things. I mean, really, I appreciate it's a little while ago now since we did this, but so it's just a reminder, really, that, you know, you'll have read it and it's really positive. So I know we're in a slightly different era at the moment, but even without the pressures and what have you of COVID, staff were under tremendous pressure, and they made great efforts to do things such as bring their training up to date when, you know, there are significant business as usual pressures on them. The toolkit, again, you know, we were successful there, so that was really positive to see. The engagement improved on the toolkit this time around, so that was really great. I know we had some reportable incidents, which are in the report, but actually it was good that the Information Commissioner's Officer, the UK regulator, acknowledged that there were no systemic problems, and they acknowledged that we'd put things in place. And actually, since then, it appears that the awareness and the communications messages that we put out are working, and the fact that the training was good is an example of that. And then also, really just to highlight, there was some really good work that we did on all things information asset owner. We had the internal audit, which we had some recommendations from, but we're forging ahead with them, slightly delayed, but they're happening. We did some great work in trying to engage more with the IAOs. We've been looking at the documentation to try and make the tools more available to people so that they can help themselves. So some great work, basically. Just, you know, a huge thank you to everybody for doing that, because it's about everybody out there. It's not the IG department. We're just there to chivvy people along and make sure that we're compliant. And then really sort of going forward, appreciating where we are now. It is a slightly different year, not just because of COVID, but we are facing different challenges, some more immediate than others. So we have coming up, for example, we've got ongoing work that we're doing in preparation for a follow-up audit from the internal audit about the information asset owners and the information asset register, which on a positive, we have the IT team developing a new one. So that's brilliant. That's going ahead. We've also got, excuse me, we have some challenges to think about in terms of training because of COVID. If the trust decides that we have to make interim measures, for example, then that would have an effect on things like the toolkit going forward. So I'm talking to the national SIGN, that's the Senior IG Network of colleagues, and also to NHSX, just in advance of anything like that happening, so we get some sort of steer from them and that. There will be a new audit approach from the auditors this year right across the NHS in terms of the toolkit. So that's a challenge that remains to be seen, but hopefully that will work. And also we've got things coming up like, dare I say it, the EU exit. The next few weeks up until the end of the year, because we come to the end of the transition period, the UK then becomes a third country. And so we've got challenges in terms of we're reaching out to people, and we will need help from everybody, reaching out to the information asset owners and heads of service to make sure that we know about any non-UK transfers, because we will become technically a third country at that point. And whilst measures are being put in place nationally, it seems likely that they could well be delayed. So we're also monitoring things that are coming out from NHSX as well, in terms of making sure that we're on ball with that. And generally, keeping up with the collaborative working that we're already doing with Airedale, because we are a joint service, so that's brilliant, and we're sort of making steady but good progress, and then trying to, once we can sort of get a handle on all the business as usual challenges, to do more across the patch as well. So we're having some nice progress, successful meetings with the likes of Bradford District Care Trust and others. So that's good. So positive, some challenges to come, but I'm positive still that, you know, with some help and with some engagement and reaching out to people, that, you know, we will still be in a good place again at the end of this year.
That's very helpful, Jenny. Thanks very much. Very encouraging to see the good opinion and the strong training rates as well, training compliance rates. So thank you for that. Paul, could I bring you in and ask whether there's anything you may wish to add to that, please?
Just very briefly, just two things really. I think one is, one of the strengths in Bradford is the fact that the IG training seems to actually mean something with our staff. I think there's good, we've got really good evidence of understanding what IG means. I think the second thing is really to thank Jenny and the team, because often IG is kind of seen in a negative way by clinicians, and they're the police that stop us sharing information. I think Bradford and Airedale have got that very opposite view, that I actually, on a personal level, find the IG team really enabling in helping us to sort things out. I'm grateful for that, and I just want the board to be aware of that, that actually the IG team has a real positive influence on how we care for our patients and how we share that information in a really safe but useful way.
Thanks very much, Paul. That's very helpful context. Thank you. Brian, would you like to come in? Yes, and Mohammed, I'm conscious you have a question as well. I'll raise that with Jenny. Yeah, so Brian, yeah.
It was really just to re-emphasise the link between the IG team and the Caldecott Guardian role, which I have to say is, you know, as Caldecott Guardian, my job has been so much easier working with like-minded people who back me up, give me the support, make things happen. And just to endorse what Paul has said, that relationship doesn't happen by chance. It's the strength of the people who work on this, who do this work. So thanks to Jenny and Graham and others. It's a very small team, but they have a remarkable impact. So certainly from my perspective, it has been tremendous.
Thanks very much, Brian. And perhaps one for you to note as well, Ray, yes, the importance of that relationship. On the point of the small team, Brian, Mohammed, one of our non-executive directors, Jenny, just asked whether, could you advise us whether you're carrying any key unfilled vacancies in your team, and is there any further support the board could usefully consider?
Yeah, at the moment we're, touch wood, we're fully staffed, but we are a small team. We at Airedale, we do have a part-time officer, which is currently being covered at bank. That's purely because of COVID, because we were very unlikely, because of the hours, etc., to get somebody in on a permanent basis. But that will be going out shortly, and it's the same individual who was doing that post before. I will be looking, I mean, we're obviously sort of, when Paul joins us and we have new CIRO arrangements in place, I will be looking at what resources we need, because we're only ever going to get more increasing, demand for advice and support. It's never going to go down. So yes, we're doing what we can in terms of doing things differently and more smartly where we can. But because we're so small, we only need to have some unplanned absence, and that can set us back weeks. And we need to be able to react to people. So we need people, we need the staff that need the help to be able to get advice from us quickly, rather than having to wait a couple of weeks sometimes. So yeah, I will be looking at that and looking at it between, Airedale and Bradford, and seeing what we can do in that area.
Thanks very much, Jenny. And I can see in chat comments on our facility that there's a lot of support for what you're doing from the board, from board colleagues. So thank you very much.
Thank you.
We're being asked with the paper to note your opinion regarding our position on information governance, and to satisfy ourselves that the data protection officer role is being effectively planned and discharged to provide us with appropriate information and assurance regarding compliance. Are we content to do that, colleagues? Yeah, okay. Thanks very much indeed, Jenny, and thank you for joining us. Sorry you had a slight delay there.
Thank you, everybody. Thank you, everybody. I'll pass everybody's comments on to the team as well. It's really appreciated.
Great stuff.
Thank you.
Thank you. Okay, colleagues, so shall we just finish off then with our quality matters, please? So taking us to the integrated dashboard, please. And we'll perhaps turn to Brian first and just ask any particular points, Brian, that you might wish to raise with board in terms of strengths and weaknesses in relation to quality, please.
Chair, thank you. Just to let you know, I've lost complete access to any of the papers. So, however, I do have on my phone, which I'll put up that Paul Southern has sent me, which is the dashboard. So forgive me if it's not quite as clear. I don't know what's happened to my connection at home, but so we've altered the dashboard, as people will recognise, to take account of the fact that we're in the middle of COVID. For those who remember, we would normally have our mortality rate reports, SHIMI and HSMR, but they, to some extent, have been paused. However, in the last couple of weeks, they've produced a new summary hospital mortality indicator report, but they've excluded patients who have had a diagnosis of COVID. So, and interestingly, our overall rate has remained unchanged, but we haven't put it in the dashboard this time because it's literally only just come out. But I don't know what they're going to do from an adjustment point of view going forward with respect to COVID to some extent. The document that I've received, there's been a time lag under the stillbirths where the narrative doesn't match the graph, and therefore, apologies, we've made a correction to that, and that will appear on the U drive. But we've seen a rise in stillbirths that we've flagged to the regulation committee before. Yeah. We know the circumstances of that rise, and we'll pick up the detail at the next regulation committee, which we agreed from the October committee. I would also flag that although we've rated readmissions as red, that's mainly because the legend that we've applied hasn't been updated, because we don't truly understand the consequences of COVID and readmissions, although the overall figure seems much lower than it was pre-COVID to some extent, but I wouldn't place too great a store on that. So from my perspective, the overall quality indicators on this dashboard are only a small subset of the work that we do, as you know, through the regulation committee. I don't propose to actually explore any more that sit under my purview. Thank you.
Thanks, Brian. And I'll bring Karen in now and then ask if there's any questions after Karen's perspective. So, Karen, anything you'd wish to bring to our attention, please?
Thanks. A couple of points. So apologies for the commentary not quite catching up with the graphs. I did put in the text before, so the graphs are correct. It's the commentary that's wrong, and we've reissued that last night. In relation to stillbirths, Brian's touched on that. We got a full report at our regulation committee last month around the 5 stillbirths in September. I'm pleased to report to the board that numbers have reduced in October, and the October figure is 2 stillbirths in October. So an encouraging return back to the levels from previous months. Just want to pick up on falls with severe harm. You'll see that there's 2 falls with severe harm reported in September. Both of these are subject to SI investigations, but you'll also notice the eagle-eyed amongst you that there's 0 reported in the SI column. That's because we go through a process of looking at incidents and referral to QOC before we declare an SI. So it's the falls at the end of the month and the SI declared the following month. Both of those 2 falls, one was a patient who sadly fell and died as a result of the fall. We have looked through whether there are no omissions in care in relation to that patient. We'll always be learning from cases like this, and that will be reported in due time. The second fall was a lady who fell on one of the community hospital sites, broke the hip. I'm pleased to report that this lady has now gone home and made a full recovery from this. You will also note that I have looked at the C. difficile graph, which I know has been a bone of contention for many, and the upper and lower control limits have been reset on that chart to take into consideration the changes in reporting of C. difficile cases from the 1st of April 2019. Happy to take any further questions, but they're the main points from me.
Thank you. Thanks, Karen and Brian. Either of you, Karen or Brian, I just had one question about the deterioration in the sepsis indicator of those receiving antibiotics within an hour. I'm assisted, obviously, by the text in the report, but I wondered whether either of you had any more up-to-date information, and indeed whether our current COVID challenges are affecting our ability to get antibiotics to sepsis patients. So could I ask for a little more detail on that, please? Brian, are you unmuted? Yeah. Thank you.
Yeah, thanks, Chair. I think there's two aspects to this. One is the way in which it's being counted. we now produce an alert system within EPR, which flags up suspected sepsis. And actually, we now know that not all those patients have sepsis. So when we're counting the denominator and the numerator for antibiotics, they're not necessarily one and the same. The second part of that is our deteriorating patient tile, which is following the upgrade in September, has been paused. It's now recently restarted. And therefore, that's another way in which we identify patients early for intervention, including sepsis. So we've had a short period of time in which that's not been in operation. And therefore, the visibility that we were seeing earlier on has been a problem. And the third, as you say, Max, the actual impact of coronavirus and the impact on staffing and our ability to intervene with patients is slower. It is definitely slower. The problem with the hour is it doesn't give you the range. And we know from the work that we've done on sepsis that patients are getting antibiotics within 2 to 3 hours at nearly 100%. It's just the hour measure is one of the most challenging. And the final measure I'd add to that, which is not always easy to find, but when you look at benchmark, the national average benchmark is around 40 to 50%. So in context, whilst it's not where we want it to be at the present, it's well above the national average picture.
Okay. Thank you, Brian. That's helpful. I'll ask colleagues whether there's any questions arising from the quality dashboard. We will be going on after the break to finance and performance. But shall we take a leg stretch now then? Shall we take this opportunity for a short break? So 10:49 on my computer. So can we come back at, what do you think, 5 or 6 minutes, something like that? Yeah, so 10:56. 10:56. We'll resume. Yeah. Okay, 10:56. Thanks everybody, and see you in 6 or 7 minutes. Okay, so for those people that can hear me talking, if you perhaps come back into the meeting, please. And we'll continue with section 4B, finance and performance. I was encouraged to note, by the way, as a board, given all the challenges we've got at the moment of seeking assurance and acting as a unitary board, that including this meeting and up to the regulation and assurance meeting in December, there are actually 7 occasions at which all the non-exec directors come together for assurance discussion purposes. So it includes 2 open forums that we've now divided in for ourselves to have discussions. But between now and the 16th of December regulation assurance, there's 7 occasions. So 7 occasions in 5 weeks where people are coming together and discussing the collective success of the organisation. So I think that's quite encouraging. Okay, so shall we move on to finance and performance? I'll turn to Saj first, I think, if that's okay, Saj. And I will, of course, give you a very warm welcome in your first public board meeting as our new Chief Operating Officer. We're very lucky to have you, Saj. It's a sincere welcome from me and the rest of the board. Great to have you with us. And shall we begin? What I would like you to do, Saj, if you would please, is perhaps just draw out any key points from the performance dashboard that you feel we should be aware of. So direct us towards areas of strength, any challenges. That would be extremely helpful. Colleagues will have looked at the dashboard, and obviously we can open for questions then. So over to you, Saj.
Brilliant. Thank you, Max. Thank you for the warm welcome. The pleasure's all mine. I'll take you through the dashboard as you have highlighted. Colleagues will have gone through, I'm sure, in detail. So I'll try and keep it high level. If there are any questions, obviously more than happy to take those. The data that you're seeing within the dashboard relates mainly to the September position for all of the constitutional standards other than for cancer, which reports 4 weeks behind. And you'll have noted that that data relates to the August position. What I would like to bring out firstly is the emergency care standard. And you've already heard from colleagues that were on the call earlier on from the urgent emergency care CBU about the excellent work that's happened. This is a 95% standard for patients to be seen, treated and discharged within 4 hours of attending A&E. And our September performance was at 88.37%. So that is a slight drop from the previous month. But what's really encouraging is that remains above the upper control limit on the SPC chart. And we do experience a level of seasonal variation with the A&E performance, because clearly in the winter months we find that the bed occupancy plays a factor on that. And therefore it is important to look back at the same time last year. And if you do that on this graph, the particular area that I want the board to note is the statistically significant improvement that you can see there of circa 8% of an improvement. And that directly relates back and provides evidence to what Sam was highlighting this morning around some of the initiatives that the organisation has put into play. And the last thing I'd like to highlight on the emergency care standard is that I also scrutinise our relative position regionally and nationally, and that comes through on a regular basis. And I'm really pleased to report that for this last week, our Type 1 performance, we were 6th out of 44 trusts regionally, and we were 25th out of 123 trusts nationally. And that is a fantastic position to be in, given the COVID pressures that organisations are experiencing. So I did really want to bring that out to the board's attention, because it's a really strong position. It's testament to the hard work that the teams have been doing and the organisational response to that particular constitutional standard. Moving on to referral to treatment standard, this is a 92% standard of patients receiving first definitive treatment from referral. It's greyed out at the moment because this is a forecasted position for September because of some data quality issues, but our forecast position is at 56.5%. you're seeing an improvement there in our referral rates, and that's down to two real particular reasons. One is, as we start to get more referrals coming through from the GPs following the pause that there was during COVID, obviously the under 18 week denominator is growing, but at the same time we started to see patients and we were able to conduct treatments. So clearly that's the reason for the improving position. That is going to be a challenge for us as we go forward because of the second wave of COVID and the impact that that is having on our ability to undertake both inpatient elective procedures, but also us having to divert our clinical teams to help with the ward pressures that we're experiencing at the current point. Of particular note under that standard is the 52-week wait position. And as you can see, unfortunately, the 52-week wait position has further deteriorated. And as at the end of September, we were at 788 patients who'd waited over 52 weeks. That position is unfortunately going to get worse before it gets better. But what I would like to assure the board on is the fact that we do have a robust clinical prioritization process, and our focus is on trying to clearly see those patients who are deemed by our clinicians as clinically most urgent, and then obviously once we can manage those clinically urgent patients, move to those who have waited the longest. And so we categorize the patients between P1, P2, P3, P4, and P5. And unfortunately, some of the very long patients are not in the P1 and P2 category, and therefore their wait time gets longer. Like I say, given the second COVID surge that we're experiencing, it is likely, and we do know that figure is going to deteriorate further. The other area that I'd like to bring to the board's attention is our performance against cancer 2-week waits and cancer in general. So it's pleasing to note that the 2-week wait standard has been delivered at 97.41%. This is a 93% standard, and this is from being referred by a GP for somebody with suspected cancer to be seen within 14 days. And we've continued to, despite the challenges of COVID, continue to deliver against that standard. And that again goes back to the point I was raising earlier about how we're focusing our efforts on trying to maintain the urgent and the cancer activity whilst also managing the COVID pressure. Unfortunately, what that means is that some of the routine activity ends up waiting longer. In terms of the 62-day cancer standard, so this is an 85% standard from referral of suspected cancer to receiving your first definitive treatment. And for August, our performance was at 81.26%. And given that this standard particularly relates to when the patient receives their treatment, they get recorded. What we're going to see is that we're going to see this performance against this standard deteriorate whilst we treat those patients that are already who've already waited beyond the 62 days. So you'll have seen from previous reports that at one point we were reaching about 180 patients who were classified as long waiters with either confirmed or suspected cancer at the peak of COVID. I'm pleased to report that's down to approximately 100 patients now who have gone beyond 62 days. So each time one of those patients is treated, your performance actually deteriorates because they're already above 62 days. So actually, although our performance has deteriorated there, we're doing the right thing by the patient, and that's the key element there that I'd like to highlight. Yeah. Lastly, in terms of the diagnostic wait, which is another constitutional standard, the standard is that patients are seen against 15 modalities that form part of this standard within 6 weeks of being referred. And this is a 99% compliance standard. So obviously very little room for maneuver. Our September position was at 53.76%. What you'll notice from the SPC chart is that has been an improving month-on-month position from April, which is great. That's largely because we've now managed to get X-ray, CT, MRI, etc., back to a point of delivery. We are, however, endoscopy forms one part of these 15 modalities that I was highlighting. And it's quite a significant chunk of activity there. And we are constrained because of the COVID measures we've had to put into place. So that means we can't get as many patients as we were previously through the same endoscopy sessions because of downtime, because of cleaning, because of equipment, etc. So that I think although we'll start to see an improving position as we have done, I think it'll be some time before we get to full delivery of that standard against the 99%. The rest of the metrics that are contained within the report are support metrics, really. So other than the board really noting them, I wasn't intending to go through them in any detail. But I am happy to take any questions, as I highlighted earlier, Max.
Thanks very much, Saj. So obviously we're looking at the dashboard, but also Saj brings to our attention the report at item 30, monthly performance update. Saj, can I just compliment you on that monthly performance update, because I found the explanatory text very useful in addition to the data as presented. So thank you for the way in which that was presented. I don't know how other colleagues feel, but I think that sort of commentary is exactly what we need to see. So, thank you for that. Much appreciated. I will turn now to colleagues to see whether there's any particular questions to tease out before we move on to finance. So, Julie, yeah, would you like to come in?
So some encouraging and challenges in that performance report, and I think some of the kind of non-urgent stuff we're going to see probably deteriorate further, and we need to recognise that, but some really good work in maintaining some of those targets. I just want to pick up at this part of the meeting, because I'm not sure where it fits, is we get the daily COVID reports through, and I think I just want, from looking at those, to congratulate the team on the flow through the hospital. So what we seem to be seeing on those is the number of discharges a day to kind of maintain that bed base looks fantastic. So I'm not sure this is the right time in the meeting to comment on it, but I just want to bring it to you, so record it as a board. The flow through the hospital is fantastic. So it just feels fitting at performance.
Thank you, Julie. Saj, how would you respond to that? Have we got the balance right there in terms of who's leaving us?
Yeah, Max, I think that's a really important point that Julie's mentioned, and I think it's unfortunate that we have to stop some routine activity. In an ideal world, we'd want to continue everything, but that's a conscious effort as an executive team, supported by our ops colleagues. We've had to take a decision to say we will redivert our clinicians. So, for example, routine outpatients that they were doing in the mornings, we've rediverted those clinicians to the ward areas. And the clinician response has been absolutely fantastic in terms of turning up to the command centre, going on to the wards. And it says Julie has highlighted in terms of keeping those discharge numbers in equilibrium to try and maintain that flow. This is a really pressured time for all NHS organisations, and what's been phenomenal is the clinical engagement that we've had has been fantastic to see. And people are going above and beyond despite the challenges, despite the effort it's taking. And you heard around, obviously, from Sam, and we've heard from the maternity team as well, the challenges that they have. And I think it's testament to the hard work that they put in, that they continue to balance the discharges with the new admissions coming in. So I think Julie's right to highlight that. And I think it is the hard work that our clinical teams do day in, day out, Max.
Thank you, Saj. That's noted with pleasure. Thank you. Thanks, Julie. No further questions, I think, on performance. Shall I move to finance now then, and invite Matthew to draw our attention to key issues from the dashboard, and also to his report at item 29 of the board. So, Matthew.
Thank you. So the three indicators in the dashboard all bring us to the period ending the 30th of September, which is the final month of the initial financial regime for 2021. For each of them, we remain on plan, which is in line with the national expectation in terms of delivering a balanced I&E position. Our cash position is broadly in line with plan. Liquidity is slightly behind, but there are no real significant issues to highlight. It's probably worth noting in the detail of the report, we have highlighted for the first month a variance against the original deficit plan that was established by NHSI. We had in previous months been reporting on plan, or actually under plan, against that level of expenditure, whereby we had a significant underspend against our elective activity work, where we weren't doing the work, so we had an underspend, which was offsetting some of the underlying issues that we've discussed previously relating to how the plan was set, looking at the month 8 to 10 run rate from 2019-20. We've had a slight movement the other way this month, so we're £1 million in addition, £1 million of additional cost compared to the plan set by NHSI. This is reflective of the additional elective work that we undertook in September. We're not anticipating this to be a problem. We do expect to get that fully recompensed in the retrospective top-up process, and we're just going through the process with NHSI now. There are no issues to highlight on cash, and on liquidity, we're slightly behind plan, but it's a timing issue whereby we were expecting to have received some public dividend capital in base cash from the centre, which is basically centrally funded capital spend, but that's now due to come in November. So in terms of closing down the initial financial regime for the end of September, we continue to report a green risk rating against all of the indicators, and there's nothing really to escalate in terms of risks at the moment.
Thanks very much, Matthew. I'll just pause for questions then before we pick up on the actual finance paper that's in this section. So, Selina, would you like to come in? Yeah.
Right. Am I unmuted?
We can hear you, Selina. Yes. Yeah.
Okay. So, as a non-finance person, Matthew, could you? That's me, not you. Could you actually, in very lay terms, give me a sense of what the impact of wave 2 of COVID is likely to be on our financial projections moving forward? I'm mindful that we hadn't factored in a wave 2 when we did the financial planning. So what is the likely unintended consequences of that on us moving forward and our ambitions for 21-22?
Yeah, so if I just take the first 6 months of the year, we spent £11.6 million or £11.7 million directly on COVID expenditure. We have in the new financial regime for the remainder of the year, we have been allocated a value around about £11.3 million for COVID expenditure, which was reflective of our expenditure through April through to July. At the moment, we've had a quick look at October and we'll be reporting to the Regulation Committee next week. We are broadly online in terms of our October expenditure position to spend what you would think about 1/6 of that £11.2 million would be. So at the moment, the wave 2 isn't out with the planning assumptions. When we think about how the plan was set, it was set through a combination of a national allocation and a regional ICS allocation. And it was the ICS allocation that came up with around about £11.2 million for the organisation. So at the moment, we are probably slightly below where the planned trajectory. But what I can say is we're not holding back on any spend that we need to incur to keep a safe service and keep the patient flow, as Saj and Julie have already alluded to, through the organisation. We've got quite a good command and control structure in place in terms of capturing and monitoring the expenditure associated with COVID expenditure.
Does that help, Selina? Yeah.
Thank you. Yeah.
Okay, thank you. Yeah. I don't think there are any further questions, Matthew, for you on that. So are we content with the board to note the key issues arising in performance and finance that have been brought to our attention by the exec directors? And if so, I will move to the paper submitted by Matthew regarding our approved financial plan quarters 3 and 4, which I think is to note, Matthew, yeah?
That's correct. Yes, it is to note because we had quite a lengthy discussion at the board development session where we looked at the mechanics of how the framework would work. We took it through the Finance and Performance Academy for approval. There were a couple of changes following the board development session, particularly around how we as a place across Bradford would handle the deficit that was reported across the 4 organisations, that being Airedale, ourselves, the Care Trust and the CCG. But very much looking at how a partnership approach might work to solving the underlying deficit. And then again, looking at how we work collaboratively with the ICS to make sure that overall the ICS delivers a balanced position. And we've signed a memorandum of understanding of how that might play out for the remainder of the year. So the detailed numbers are included in the paper, so I won't go through those in detail, but just recognising that to deliver our plan did require a CIP of around £3.94 million. Having a quick look at the October position, the underspend as a result of the second wave impacting on our elective activity, we're probably going to report a position that's better than plan for October, which gives us a degree of assurance that the overall plan for the year will be hit, albeit we do recognise that there is an impact on our ability to deliver elective activity. The current numbers do also exclude any impact of the elective incentive scheme that was proposed, but we've been advised to not include that in the numbers in terms of our October position. So we understand the mechanics of the position. October looks like we're broadly on plan from a planning perspective, and from a forecasting perspective, we've got a best, worst and mid-case scenario. Our mid-case most likely scenario is that we will hit plan based on where we project the run rates to continue. Best case could be slightly better than plan, and worst case maybe at worst £1 million worse than plan, and we'll be feeding those numbers through to the ICS over the forthcoming days. So not a great deal to update in terms of what we've already made the board aware of in terms of the plan for the remainder of the year.
Thanks very much, Matthew. So the ask of board is that we note the submission of the plan. Are we content to do that? I think we've been well briefed on this, yeah? Okay, we're content to do that. Thanks very much. So before I move away from Finance and Performance, perhaps just turn to Julie and ask whether, Julie, as Finance and Performance Academy lead, is there anything else you would wish to bring to board's attention regarding what we've heard this morning? Nothing further, no? Okay, that's absolutely fine. Thanks. Okay, thanks, Julie. Moving to people then. Pat, shall I come to you, please, to again just bring to our attention the key issues from the dashboard, and there's a paper regarding flu vaccination, and we said we'd also just have a think about COVID vaccine there as well.
Yeah, sure. In terms of the dashboard, what I'll concentrate on are the sort of metrics where we've got new data. So the metrics on engagement and equality and diversity, where we've got 6 monthly updates, which you won't have seen before.
Yeah.
So in terms of the engagement metrics, you'll see that we've seen an increase again in contacts with the staff advocacy service. We have been promoting the service quite strongly over the last few months to ensure that there is staff awareness around what the service can do and how the service can support members of staff. We were also sort of keen to start to signpost staff again to that service, rather than staff sort of defaulting to CARES as our EDI lead. And what we are seeing, again, through the increased use of the advocacy service, a rise in informal resolution of cases. We are undertaking a service review as part of our whole approach to dignity and respect in the workplace. And you'll see that we have developed a webinar on civility in the workplace, which has actually evaluated really well. In terms of harassment and bullying outcomes, in the last 6 months, we've had 12 new cases reported, 9 of which are ongoing. The complaints in the main are largely colleague to colleague and represent breakdown in sort of team relationships and dynamics in the majority of those cases, rather than manager to colleague bullying as such. There have been sort of 4 cases completed. You'll see 2 have resulted in disciplinary action and 2 have resulted in informal action. This period also coincided with a national social partnership agreement that with routine employee relations cases and investigations should be paused during COVID hence the delay in terms of some of these investigations. We're now sort of ensuring that these cases are not subject to any further delays, and that investigations have now restarted. As we do acknowledge that sort of investigations for all parties really can impact on the health and well-being of staff who are subject to investigation and can lead to staff going off sick. So those outstanding investigations have all restarted. In terms of staffing, nothing really to highlight apart from staff turnover, which you'll see from that is that we see a continued dip. And I must admit, I've never seen staff turnover as low, but I think it does reflect the sort of economic position at this time that, you know, it's not, people don't see it as a good time to be moving employers, and people don't see it as a good time to be leaving the trust.
Yeah.
So in terms of our equality and diversity indicators, so you'll see that in terms of our BAME overall workforce, our workforce numbers continue to increase, and we remain ahead of our 10-year trajectory. So we are seeing local people being recruited into entry-level positions, and we continue to see sort of proportionate, I can nearly say that, proportionate numbers of doctors in terms of trainee positions and consultant positions being recruited in the trust. In terms of internal promotions, we are seeing BAME staff being promoted from bands 2 to 3, bands 4 to 5, bands 6 and 7. But what you'll see is we're not seeing that corresponding increase at our senior leadership level. To put sort of numbers into context, we have sort of 334 staff at bands 8A plus, of whom 47 are from a BAME background, and we've only seen an increase in one BAME member of staff in the last 6 months.
Just say those numbers again, Pat, please. So it was band 8A and above.
So band 8A and above. So we've got 334 staff in that category.
Yeah.
Of whom 47 are staff.
Yeah.
And we've seen an increase in one BAME member of staff in the last 6 months. So you'll know from this sort of RES action plan that we submitted to Regulatory Committee last month, which is also in these papers, that sort of senior leadership, improving representation at senior leadership is a key focus of that action plan. And the actions obviously include a sort of an overhaul and review of our recruitment and selection policy and practice, which is undergoing at the moment. We're looking at sort of each 8A and above post that comes up in terms of what posts we can deploy positive action on. We recently did that with Karen's deputy post, and have now sort of paused recruitment for 6 months, well, for 3 to 6 months in terms of that post. And we are obviously launching both our internal and external mentorship programs from January, plus promoting the BAME fellowship. So sort of in terms of senior leadership, that does remain a priority for us and is the key focus in our RES action plan. What we have seen, we haven't had any BAME members of staff in 8A plus leave in the last 6 months, which is, so we're not seeing a sort of revolving door in terms of staff turnover. And so we are sort of working, and KES is working through the BAME network with those senior staff in terms of what else we can do. and what will make a difference. So we will obviously continue to report through the People Academy and board in terms of the actions that we take. In terms of health and well-being, so staff sickness remains very challenging. We have in September seen an increase in COVID sickness again, and in self-isolation, and that has increased again in October. Yeah. Our position this week in terms of COVID staff absence is that we are now at the same level as we were in mid-May. So we were up. So we now have over 300 staff absences around COVID. And certainly talking to my colleagues in the other Wyatt trusts, they're seeing similar increases. In terms of non-COVID absence, which obviously in some cases may be COVID related, our highest reason for absence is anxiety, stress, mental health conditions. And we've talked a bit through other sections in terms of in terms of what we are doing to try and support staff and what we continue to do. So I am sort of for regulatory committee next week, sort of doing a written report this time in terms of health and well-being and resilience, so that you're sort of totally up to date in terms of where we are and what we're doing. Do you want me to move straight on to flu?
No, I think I'll pause and allow just some reflection on some of the key metrics there, please, Pat. Just before I do, we did say we'd pick up on the point that Karen had raised about a rising tension amongst some staff in relation to staffing levels and the challenges that people are seeing. We've seen a rise in FTSU referrals, for example, for you to speak up. Do you have any perspective on that, or a plan to try and manage some of those concerns?
So I think for me, it's very much involving staff in the conversation, ensuring staff are sort of are informed. One of the things coming through is sort of, and one of the things coming through this sort of the bullying harassment complaints that we're getting is just a tension between people, and it is that point. You know, people are tired, people are fed up. Some people feel that others in their team aren't sort of pulling their weight, you know, that sort of thing. So it is very much, and we are sort of deploying OD staff where we can to help with those team relationships and team building. And it's just really a recognition of how staff are feeling and what we can do, even if it's little things, to help with that.
Yeah. Okay, thanks, Pat. That's helpful. Thank you. I can see that John would like to come in and Selina too. So I've noted you both. So John, would you like to start?
Thank you, Max. Yeah, I'd just like to first of all commend the work that's going on around equality and diversity. I think it's really positive. There are some really positive trends, and I'd just like to have recorded that the meetings I've been in with Black and minority ethnic staff around risk assessment and such like, the attitude's been really positive. So I'd quite like that to be minuted, because I think we've got a strength there. Just a specific question. Unfortunately, I know the question, but I really don't know the answer, I don't think. So apologies, it will just be a very open question. I think ever since I've been here, and it's not uncommon for this senior level issue to be a challenge around representation, and the 8A and above, I think, is what you referred to, Pat. I wonder, given what's going on in the world generally, I won't rehearse those arguments, I'm sure you know them, and in organisations specifically that we've heard about recently, is it time for some radical action in this area to make sure something happens? Because I get the feeling, and I don't think this is a criticism, it's just a fact, I think, that you know, we are stuck with this challenge and it doesn't seem to be shifting really, and I just wonder whether we need a radical think about what we can really do differently to improve that pipeline and make a difference at 8A and above. Thank you.
Thanks, Sean. Pat, are those conversations happening?
Yes, they are. So they're happening both within the trust and they're also happening at West Yorkshire and Harrogate, obviously ICS level, and on the back of the Dame Donna Kinnear Commission report. I think Mel might.
Yes, I'll bring Mel in. Yeah, Mel, would you like to unmute? Yeah.
Well, that just answered it in the sense that I was just going to comment on the Donna Kinnear report, which I will have included in my update, Chair, which I'll will come on to later.
Okay, Mel, thanks. Yeah, and Mohammed, I know you and I have spoken about this as well in recent times. So, would you like to come in with a perspective?
Yeah, just a couple. I think one reflection and one possible question for Pat. I think I really welcome that almost every board meeting we're spending some time talking about this stuff, and I think that's really welcome and really important. I've been involved in a couple of recruitments, both at Bradford and at the other place at NHS Digital, and just some thoughts and reflections from my experience on those interview panels. I think with some of our staff, we've not really been. I'm not sure, creating the space for them to find the time to really look at issues of inclusion and equality. People are so busy, and I totally get that, both here at Bradford and at NHS Digital, but we've not created the space for people to take some time out of their kind of day-to-day work to then step back and look at the issues around equality and inclusion. And I found that in some of the recruitment that I've done, that individuals have struggled to articulate the issue or struggled with sometimes with the language. And I don't think that's anything about them. I think it tells us more about the organisation, that perhaps we haven't given the support to those individuals and create some space for them. So the question, I think, Pat, my question for you, Pat, was going to be around how do we ensure that for our staff at all levels, that we try and carve out some space for them to be able to take away some time to look at this issue, and how can we support them to do that? And then the second bit linked to that was, again, just around recruitment. Max, this is a question I think you and I talked about.
Yeah.
I think it's really important when we are doing recruitment that we try and get the best out of our candidates. And I wanted to propose something that might sound a bit radical, Pat, but it was around, you know, to get the best out of candidates, perhaps what we should do is give the questions to the candidates in advance. And I know some organisations do that. And that allows candidates to think about and prepare for the interview questions, and everyone's got the same opportunity. So no one's caught out. You know, that's not how an interview should be. It's not about trying to catch someone out at an interview with a gotcha question. It's about getting the best out of them. And that's just another thought about how do we get the best out of our staff and our candidates.
Thanks, Mohammed. Pat? Yeah.
Thanks, Mohammed. Yeah, in terms of your latter point, Max had fed that back to me as a point to consider. So it is an area that we're doing from an HR perspective. We're doing some research on, and then are feeding that into our recruitment and selection policy review. So we will certainly give that some thought. In terms of your first point, I think it is really difficult at the minute to carve out any space for anything, but I do totally get your point. And I think one of the things we've probably lost is we went to online equality and diversity training for the whole workforce, really. And I think we've lost something in that. And we are sort of reviewing, and again, that's also in our sort of RES action plan, RES and WIDES action plan. We sort of are reviewing our whole approach to training around EDI, and to, when we can, make that more face-to-face, make that more conversational, challenging, rather than it be a sort of online training, which can end up being a bit of sort of tick box.
Thanks, Pat. I think what we'll do, I mean, rather than try and design a solution here, I think we're getting a clear message from board that we would support some strong action and some new ideas and new thinking, Pat. So it's pleasing to hear that that's in the mix. Celine, I know you're coming in, but I think Brian and John may just have some points to raise about this particular point. So Brian, you wave your hand there to Bishop. Do you want to come in now? Yeah.
Thank you, Chair. It was really just to reflect on consultant recruitment and how we actually recruit a significant number of consultants who are from a BAME background. They're senior people we need to understand why we're so successful at that when we're less successful with 8A and above under the Agenda for Change construct. There's clearly got to be something that we're not quite doing right, because we don't have the same problem from a consultant perspective. And that probably starts many years before in the way that we support the trainees and the way they feel part of what we offer as an organisation. So I believe that the work, it will progress. It just takes, there isn't an instant cure to some extent, and it just takes time for that sort of shift where people start to see the type of recruitment and the way in which we're recruiting people and feel more confident in it. And it's like that generational shift. Once you start to make the progression, suddenly you start to see the recruitment like we've done with a consultant workforce.
Thanks, Brian. I guess in some ways we have, as an organisation, to find time for that development to happen as well, don't we, for individuals to develop. Yeah, John, you were going to come back in as well. John, would you like to make a comment on that conversation? John Pressure? Are you there, John? I'll read your comment. I believe there should be a mix by questions in advance and questions on the day. As often, can't just tell exactly what you're saying there, but I think the point is that you're unmuted, you're in, yeah.
Yeah, sorry, I couldn't get off mute. Yeah, well, all I was saying was I think there should be a balance on questions in advance and questions on the day, because often life is that you do have to respond to stuff immediately and off the cuff, and it's a skill we might want to assess. So I just think there needs to be a debate on it. That's all. Okay. Thank you.
Thanks for that, John. I think what we've got is Pat. Mohammed, I did follow up on our conversation and forwarded our thoughts to Pat. The other thing was the usefulness, the utility of stakeholder panels, which I'm seeing more and more, and I find that a really useful input into the interview process. So we've proposed extending those a little so that we can really see somebody engaging and discussing with system partners. So, Pat, I think we're assured that this is very much in the mix, these conversations, this idea perhaps of some pre-knowledge of questions beforehand in an effort to test somebody's ability to actually research and answer. So, yeah, thanks very much, Mohammed. Yeah, Selina, shall I bring you in now for your point, please?
Thank you. I'd just like to echo what John said about a radical solution. I think we've been talking about this for a long time now, and it even predates before we joined the board. So I think this is something that we need to try and really get to the nub of. And I think the other issue here is that given the fact that we have the demographics that we have, the challenges that we have, it is really important that we understand EDI and intersectionality, because that actually creates the work for this organization. And if we don't understand it, we can't respond to it and we can't use our resources appropriately. So we're actually throwing resources at things that we don't understand, and that is a waste. And I think if we're a public organization, we should be looking at it in those terms rather than this is a good thing to do. This is actually about sound business sense, and we're not getting to that point. So I think we need to focus with that mindset. And the other thing that we've been looking at is the plans, and the plans are great. They're high level, and a lot of effort has gone into developing those plans, but they need to be owned at every level. And where do we get the assurance that that plan is being cascaded down and is owned at a directorate level, at a CBU level, at even team level? Where are the targets? Where are the, how do we measure the change other than at this high level where we see a graph?
That's really helpful, Selina. Thanks. Do you think is our existing infrastructure with the People Academy sufficient to try and progress that work?
I don't know, because I've only been to one academy meeting and the discussion was very good.
Yeah.
But I don't know about the performance side yet. I have to see it.
Okay. I didn't know if you were thinking there was a particular model you wanted to bring in to try and progress this sort of work, or whether you felt it could happily progress within the People Academy. And it may well do by the sound of it.
I think it's for the exec to consider how they think it might work best, because they're the ones who have to deliver this. But this is as somebody who's an outsider looking in. in a sense with some knowledge of what the trust does.
Yeah, well, unitary responsibility, Selena. So, you know.
Yeah, absolutely, absolutely. Happy to advise and steer.
Yeah, and it's a strong point, and it's a strong message that's being given by both. So, Mel and Karen, I can see you'd like to come in with comments. So, Mel first, then Karen.
Yeah, so I'll touch on this a little bit when I come on to my report, Chair, but I mean, Selena's absolutely right. This is not a problem that is going to go away. It's a challenge that is significant. It's been perennial, and our best endeavours as an organisation has not really seen the progress that any of us would have wanted to have seen. My view is, of all the trusts in the country, we should be top class at this. You know, this should be one of our greatest ambitions, because if anywhere has the need, the necessity and the environment in which to get this right, it should be us. So others should be looking to us to say, what is it that they are doing in Bradford? So it's just an acknowledgement of the fact that Selena's absolutely spot on in her observations. And the second point is, in direct answer today, well, where do you get the ownership for this? When we kind of made some of the changes around how, since I arrived in the trust, how we operated as an exec team relating to clinical business units. And I'm sorry I wasn't here for the first part of the meeting, because that really was another signal of the intent that I have around the visibility of clinical business units and what they are doing, and putting them in the driving seat and having responsibility and accountability for what happens in their clinical business unit. So the idea that we have something on the agenda that is get to know the clinical business units from a board perspective is really important. So in that vein, between the first wave and the second wave of COVID, we've done a complete cycle of one-to-one meetings with every CBU and the executive team. And we were just about to start on the second cycle of that. And over time, that will finesse into the kinds of conversations that have started in the first iteration about, tell us who you are, what are you about, what are your challenges, what is your vision for your CBU, what do you want to see being done better, to some very potentially more challenging conversations with them about their performance in these areas of concern, or stretch targets, or improvement plans, or efficiency programs, and how we can, much like the focus we've had on maternity services, how we can have through that mechanism that kind of scrutiny with all our clinical business units. So that, for me, Selena, in answer to your question, is the mechanism by which we will hold CBUs and their leadership teams to account, but also in a supportive way, in terms of asking the questions of what can we as an executive team do to help support and create the environment for you to do better in this area.
Thanks very much, Mel. Thank you. And Karen, I think you wanted to add to that as well.
Thanks, Chair. Selena touched on it a bit when she mentioned the People Academy that we had probably 6 weeks ago now, I think, all the days merging into one. So we had probably a good conversation, about 45 minutes, I think, just around this very issue of recruitment, that 18 and above. And we talked about lots of things, but two of the things I'd like to raise from that discussion are, we talked about it's not just about developing people and giving people headspace and opportunity. That's really important. And we've been doing that, encouraging people to go on courses, putting them through things for a number of years now, and it hasn't quite worked. So what else? So something about actually education of the people that are recruiting, because there is still something to explore about the fact that we can unconsciously recruit in our own image, or when we listen to answers to questions or ask questions, they are based on our own sort of personal experiences. So mine as a white Christian woman. So that was an important piece, I think. The other is that whilst we are underrepresented proportionally for 8A, we are significantly overrepresented in the very lowest bands of the organisation. So again, what can we do there as well? Because, you know, that is also an indicator that says, how can we have so many more proportionally staffed from BAME backgrounds in the very lowest grades in the organisation? And I think we need to, you know, be mindful of that too. Saying all of this, we know that the committees have, we've just stepped them down on the academies again because of COVID, but we do still have time as a board to come together, and we've got such diversity within our board and such, you know, really keen minds. We should be able to have an open and honest conversation about this, and maybe it's something for board development, and maybe we consider bringing in some other people to talk and work through that as well, because otherwise I think we'll just continue to have the same conversations in this forum. But because we haven't got the headspace ourselves to move things on, it might be that we can't do so. So I would welcome a wider board discussion, maybe in a less formal setting, where we can really understand and have some honest conversations.
Okay, thanks, Karen. Let's capture that. And we're getting some very clear steers as to how we do consider this a priority. So thanks very much, all. I'm going to move us on now and ask Pat to bring to our attention the paper regarding healthcare worker flu vaccination. It's gone for approval, but I think that's in relation to continuing the work we're doing, is it, Pat? Yeah. So what would you like to draw to our attention regarding that, Pat, please?
Okay, so it's just to say, so it's a requirement of the National Flu Immunisation Programme that we complete a self-assessment against a best practice checklist, which should be published in public board meetings. And that's what you've got sort of in Appendix 1. It is a prescribed template with a prescribed self-assessment matrix. You also have the paper that went to our executive team meeting in August, which was a sort of a review of the 1920 flu programme and our plans for this year. So obviously it is to note that our uptake ambition for frontline health and care workers is 100% offer and take up. And our plan this year is different to previous years, again because of COVID. So it is built primarily around peer vaccinators with then clinics, pre-bookable clinics then as a backdrop to that, as we can't have sort of the drop-in clinics that we've had in previous years. In terms of governance, there is sort of clear governance this year in terms of our flu programme feeds into the system flu delivery group, which is chaired by Karen. As of Monday, we'd given 2,577 vaccinations to frontline staff, which is around 50% of our frontline staff, and similar performance to the same time last year. We did just talk this week about some myths again that are coming up. Re-flu and with the link to the COVID vaccine. So we're doing a big sort of comms campaign over the next sort of week or two. Read this. So there's a bit of a myth that if you have the COVID vaccine, you don't need the flu vaccine. So people are, you know, are sort of self-selecting in a way not to have the vaccine. And there's also, because of early communications around the COVID vaccine, that if you had your COVID vaccine, you couldn't have flu within 20 days of that. That has also been putting some people off. So again, that guidance has changed. The current position is that you need to have a 7-day gap. So again, we are going to be communicating that out and having a very big push in terms of flu uptake in the next 2 weeks. I suppose in terms of trying to pick up on Barry's point, and like some of my colleagues might have further information, in terms of the COVID vaccine, we're picking from a workforce perspective, we're picking up 2 sort of very clear sort of opposing schools of thought. So there's one school of thought that people can't wait to have the vaccine and they'll be first in the queue, and I think it's really important to have. And that's probably the larger group of staff. But there is also a bit of a sort of substantial minority who are saying, no, I'm not going to have this. I don't think it's safe. It hasn't gone through the full, trials process as a drug normally would. And there's sort of that school of thought as well on that. It's obviously not going to be mandated. And I suppose we'll just need to think how we sort of encourage maximum uptake in terms of protection for staff.
Okay, Pat. Obviously, we'll allow you the time to have those discussions with exec colleagues. Yeah. Okay. Thank you. Pat, what's the ask of the question in relation to the flu paper? What's the ask of the board in relation to the flu paper?
So obviously to note the self-assessment checklist.
Yeah.
And really to restate the commitment that our ambition is 100% uptake of frontline health and care workers. Thanks.
All content to do that? Yes, thank you. That's great, everybody. And Selina, just ask whether you have any final words in relation to workforce that you'd wish to draw board's attention to.
Just like to say that the staff is our biggest asset. It's our biggest expenditure. It's our biggest resource. And Pat and her team, as I've said previously, do an amazing job in looking after the well-being of that. They've, facilitated, coordinated, and cajoled and overcome many obstacles and barriers. And I think it's clearly a testament to the teamwork of the exec, really, in terms of ensuring the well-being of our staff. And I'd like to thank everybody really on that, because it's a team effort, and we're seeing the proof in the pudding in the fact that our staff are coming to work every day despite the challenges. Yeah. So thank you for that.
Yeah, thanks very much, Selina. Thank you. Okay, we'll move on to partnerships now then, please. So John, reflections on our work with partners locally, and you also bring to our attention our strategy, people, partners and place.
Yeah, I'll do both those things together if that's okay, Max. And I apologise, there's a pneumatic drill outside my office, so if it gets too loud, you'll have to give me a signal and I'll mute or something. Right. So I already explained, I think, when we were talking about the strategic risks, that in respect of partnerships, we're doing a rethink on those. We've closed some, and we're going to do a fresh assessment of the work at West Yorkshire level to decide whether we still have a strategic risk there. And if there is one, it's much more likely to be about the risk of not capturing the opportunity rather than the risk of bad things happening, which is very much what we did about the place-based risk. Well, we need to do the same, I think, for the dashboard, because I think the way that the partnerships dashboard is structured at the moment probably reflects a point in time when we first created the dashboard, and talks about the Airedale collaboration as a kind of discrete entity. And what I've already said is I think that's now swept up within Actors One, and so it should be. Talks about stakeholder engagement as a discrete exercise, and I think we're starting more and more to weave that through the other programmes. And then talks about vertical and horizontal integration. We probably wouldn't use that language anymore, though we might talk more about the place and the ICS and so on. So there's three things I want to highlight beyond that, beyond the kind of technicalities of the dashboard. The first is that Actors One continues throughout the pandemic. I mean, clearly, we probably can't give it quite as much push and emphasis as we would want to, because there are, urgent priorities going on at the moment and staff are extremely busy. But that said, the decision's been taken that we continue to support the programmes within Actors One. I'm one of the SROs for diabetes. Karen is one of the SROs for respiratory. Saj is the SRO for the Access programme. And I think that's really important, because I know I've used this gag before, but kind of channeling Donald Trump, there's more to life than COVID. It's massive, it's existential, it's a really big and difficult thing for us all to handle at the moment, but we have to keep our head up and look at the broader picture and the work we have to do on a range of different fronts. And I think Actors One helps us with that in terms of maintaining an appropriate level of emphasis, but working with partners across our place. The second thing I suppose I wanted to say is that, and Mel may touch on this in her update, we are actively cooperating across the place in the way that we respond to the pandemic, whether it's through the outbreak board or through the local partners, or especially through the communications. And we're getting a bit more fleet of foot about the way we communicate things effectively with consistent messages, whether it's, still here for you or addressing fake news. And the third thing I wanted to say is, of course, last week, we, as an organisation, BTHFT, published our People, Partners and Place. In the interest of time, I won't pull the slides up, but you have all seen them anyway. And indeed, you saw them when we had our last board development session, and your feedback has informed the shape of the thing that we finally published. We also drew on advice we got from governors and from talking to other system partners. So People, Partners and Place it's a recognition of where we are now, but it's also outlining where we want to be in the year ahead. There aren't radical new things in this. That was never the point of it. It was more about saying, here's all these different strands of activity that we're doing, and we want to describe them in a coherent way so you can see the overall picture and the direction we're travelling in. It's the beginning. It's not a new strategy in itself. It is the beginning of the process to develop our organisation's new strategy. And that's really important. We already have a strategy. We haven't ripped that one up, but now is the time to have a think about what would our new strategy look like. And clearly that's going to be very different from a pre-COVID world. And there's lots of other considerations as well. The digital agenda is massive, for example. So we've pushed People, Partners and Place out across our organisation. We've done it through screensavers. We've got the plan on a page. It's been on the video walls and so on. And it gives us, we've used the term guiding star, it gives us something to help us in the months ahead, just to remind ourselves these are the things we said we were going to do. I know the question will be rightly, but where's the detail? Where's the plan? Where's the timetable? Where's the smart measures, etc.? They're not in People, Partners and Place. They are in the components. So if you were to look at, well, we've had a conversation today about outstanding maternity services. That's one of the things featured in People, Partners and Place. And obviously, there's a whole load of work underneath that headline telling you about what we hope to achieve, in what timescale, and how we'll know if we've got there. Finally, a word about next steps. When I did ask for feedback from system partners, the comments I got really were, that's great, and what about something for the whole place? Do we maybe publish a single strategy for the whole place, etc., etc.? Our thinking at the moment is, in time, it would be nice to have a single strategy for the whole place, but perhaps as a more practical first step, what we could do, and I'm using Mel's words here, is perhaps we could just produce a compendium. We could pull together the existing strategies and plans in one place with a bit of overarching narrative. It could be a web page, for example, where we just say, here you are for the Bradford and Craven Place. Here are the strategies and plans, and here's some narratives to explain how we're all pulling in the same direction. And I imagine that would have Actors One running right through it. So we'll be very keen to do that, and we've already fixed up to start to talk to colleagues from the CCG, the Care Trust and Airedale to do something quite quickly on that. And then the second kind of next step is beginning the broader piece of engagement to develop our next corporate strategy for the next 5 years. And you will all, of course, be involved in that, and we'll bring that conversation probably to a future development session. So I'll leave it there, Max, if that's okay.
Thanks, John. John, can I just check with you will you be looking at particular academy leads, for example, to note the relevant points of the People, Partners, Place strategy in order to steer conversations towards what we are saying is important for these coming months? I'm thinking how we're going to weave this into governance.
Well, I think what I would say is we're already doing that, but we'll the proof of the pudding's in the eating. But as I say, we've not invented fresh things here. We've not invented fresh sub-strategies. There's no rabbit from the hat here. There's no brand new thing that we're announcing. Rather, this describes a number of programs of work that we're planning to do over the coming year. And yes, I would absolutely expect them to be discussed in academies, but That's not something fresh we're saying today. You weren't expecting this, now you're going to do this. Rather, it's about saying, so Pat's talked about how in the People Academy, there was a significant amount of time spent discussing BAME representation and recruitment and so on. So one of our strands of people partners in place is about ensuring BAME colleagues are actively, proactively supported. And, yes, I would absolutely expect that to be covered in the People Academy. Likewise, outstanding maternity services and quality and so on.
Okay, thanks, John. Thank you. Any questions of John? I think we're being asked to note the progress and his work in keeping partnerships alive, but also in providing a steer for us in the coming months with people partners in place. We're content to note that? Yeah. Okay. Thanks, everybody. And I'll turn now to Matthew. Matthew, we have the report from the Audit and Assurance Committee. Which I think, Barry, have you authored that or contributed to it? I'm never too sure when I see that.
So Barry's kindly authored the document.
I thought so. Thank you, Barry. Yeah. I will turn to the Exec Director first and ask if there's anything you wish to bring to our attention, Matthew, before just checking with Barry that we've covered.
Yeah, just to draw the board to attention to two substantial items that were discussed at the audit committee. Other than the standing agenda items, we had a lengthy discussion with John in attendance to discuss the new governance structure and how the audit committee could complement the assurance process and how that might work from throughout in terms of the audit committee structure and how we can bring assurance. And a further point around, is there anything our internal audit team could help to help develop that structure, but also any work that may be undertaken, say, the post-implementation review to make sure if it's working effectively or not. And the second item, just to draw attention to, was Brian, the Chief Medical Officer, joined the meeting to take us through a bit more of a contextual discussion around how clinical audit interfaces with the quality improvement programme, and just to bring the committee up to speed. And it was a very helpful discussion around understanding. The other items are much focused on the normal work plan and the standard agenda items.
Thanks very much, Matthew. Barry, would you have anything to add?
No, nothing else. Thanks, Matt.
Thank you, Barry. Okay. We're asked to note that, colleagues. Are we content to do that? Yeah, okay. Thanks very much, Matthew and Barry. That's great. Mel, so this is an opportunity, I think, perhaps for us just to invite you into the meeting and to ask whether there are things you want to bring to our attention from the CEO update, please. Mel.
Thank you, Chair. And apologies because I've got the same pneumatic drill behind me that John referenced, if it gets a bit loud. So what I've tended to do in my verbal report to the board is to construct it in the sort of three levels in which we are active as an organisation. And previously I've started with the West Yorkshire and Harrogate partnership and then talked about place and then the organisation. But to mirror people, partners and place now as our sort of overarching strategy, I'm going to turn that on its head. I'm going to start with people. And when we kind of reference people in that strategy, we're talking about two discrete groups, one being our patients and the other being our staff. And from the perspective of people, therefore, for the period that we're talking about, the last sort of 6 weeks or so, there has only been, as I'm sure people will appreciate, one game in town. And that has been how we prepare this organisation to respond to the second wave of the pandemic, with the uncertainty of what that might bring in terms of the numbers of patients and the presentation, but with the certainty that it would be much more difficult this time. And we were certain about that for a couple of reasons. One is that we appreciated that we were in the throes of delivering our restoration and recovery plan, which meant that our attention had turned quite thankfully away from such a concentration on COVID and more towards addressing the restoration of business as usual. So starting to see those patients for who they have been waiting for long periods for either outpatient appointments or elective procedures. And the second reason is because we knew that this second wave then was going to fall, and has indeed fallen, in winter, in the winter period, and with that comes the additional burden of dealing with the seasonal illnesses that we would normally see, and that would normally cause quite significant pressures on us as an acute trust through the course of winter. And I guess there's a third reason, which is equally as important, and that is because our staff in this scenario have been through this once, and the organisation has been through this once. So the amount of stress that we are carrying as an organisation, the sheer exhaustion really, and the tiredness of people for whom in Bradford, pretty much, maybe not uniquely, but certainly unusually, we had COVID throughout the summer period where other organisations up and down the country never did. So for some of our staff, COVID really never went away. The numbers may have declined, but it never went away. So when we saw that schools and universities were reopening and the lockdown had eased, we began to become concerned in early September when the numbers started to increase. And from the initial testing and the emergence of the transmission rates in Bradford, where at one time we were kind of the second worst area in the country for the numbers of COVID, people in our population testing positive for COVID. We've kind of fluctuated since that time between that sort of ranking of second. I think we've gone as low as 15 or 16 in the preceding weeks, and that has fluctuated. And this week we're 9th highest local authority rate in the country. And in respect of that, our rate per 100,000, and from an operational point of view and a concern point of view, you know, certainly anything above 550 per 100,000 is quite alarming and a cause for concern, because we know that will then manifest in presentations to acute care. Our number as of at the end of, weekend in the 9th to the 15th, which is where we still are, it was 586 per 100,000. And that was a deterioration on the previous week, in which we were 447. So we know, because of this familiarity that we've now gained around the 2-week timeline, that we are still in the throes, well and truly, of this second wave of the pandemic, and we don't know whether the high number of patients that we have seen that has significantly surpassed our previous peak of 105 at 153, whether that really is the true peak in the second wave, or whether or not there is more to come. And the next couple of weeks will, I'm sure, reveal that. So, as you might imagine, our time has been very much taken up by the preparation and creating the bed capacity and the resilience in our responsiveness to be able to provide good care for these patients who come along, and our normal activities in respect of urgent and emergency care that's not COVID related, and at the same time trying, amidst all this, to continue to provide acute semi-planned care for those patients whose condition would otherwise deteriorate. So we're talking those terms about cancer patients primarily, but not exclusively. And in that regard, we've had to be incredibly agile in creating much more RED capacity, RED being COVID capacity, than previously. So we've got something like, I think, between 8 and 10 RED areas receiving patients across the hospital today, and our numbers are 140 inpatients. But differently this time, the sort of pressure in critical care that we saw in the first wave has not necessarily been replicated. And that in part comes as a consequences of us learning as a clinical body more about what sort of interventions and treatments work better. And in the first wave, we quickly came to learn that the use of non-invasive ventilation as the primary treatment for our worst COVID cases proved to be very successful. And in that regard, we've put much more of a focus on that in this second wave, which is great because it means that the pressure is not on critical care, but it does create pressure elsewhere across our general bed base as we step up more and more beds to be able to have that non-invasive ventilation capacity. And all that confers a much higher level of staffing and a richer skill mix to be able to care for those very critically ill patients. And that led us to a decision 3 weeks ago to stand down much of the routine work that had been a feature of our phase 3 restoration. And we did that to create the staffing capacity to be redeployed into inpatient areas to look after our staff. And that's important because it speaks directly to the issues that I've referenced, which is our staff resilience, but also the impact of sickness and absences through isolation and quarantining, or our own staff suffering from COVID. So I think we have, we've been agile. We have a different level of assurance now in respect of, in the previous wave, of course, we were trying to obtain the right level and type of equipment in high volumes. We have some greater resilience in those areas now because we have stocks and supplies of those equipment in larger number. And another feature of the first wave was the uncertainty about the supply of personal protective equipment, which was a real concern to our staff. Although we never actually ran out, it was the fear of running out that was front and centre in most of the staff's day-to-day consciousness. And we have a much more resilient supply of PPE as a consequence of work that has been done nationally and regionally. That gives us the assurance that that is not going to be a feature that we should necessarily be worrying about to the same extent, which is a good thing. But in terms of the impact on our staff, you have heard a lot of that from Pat already. But I just wanted to point to some of the specific areas that we are putting our efforts and energies into supporting staff. First and foremost, there is the redeployment strategy. Be under no illusions, the biggest relief that we can offer to staff under these circumstances are more pairs of hands to help. And so if that means us calling upon the services of people whose day job is an admin and clerical job, but we have the ability to retrain them to do something that is adding value in a clinical sense, whether that's distributing PPE, whether it's sitting with patients who need that extra emotional support, or just some observation on patients who may be confused and wondering, all those things help significantly. And that's why the redeployment strategy has been really, really important and quite successful. We have Wellbeing Wednesday, in which we kind of really push and promote the different services, the suite of services and support measures that are available. And just this week, we are trying to be as inventive as we possibly can. And someone came across the idea of having a dog that we could loan out to staff so that they can walk around the trust in their lunch breaks to offer some sort of mindfulness and release. And it sounds weird and wacky, but actually there's a very strong evidence base about the therapeutic benefit that pets bring. I saw on Twitter just this morning a husky therapy dog in the middle of the A&E department at Barnsley Hospital, with the staff sort of getting some comfort and reassurances and mindfulness and well-being opportunities in looking at that. And to be honest, under these circumstances, you know, we should be trying anything really that people are suggesting as ways of combating the stresses and strains that people are feeling. But more tangibly, I guess, we have put money into designated psychology support posts. So just last week at the exec management team, we approved the appointment of 2 senior psychology posts whose role it will be to support staff exclusively. And that's a big commitment from our point of view to help support staff, particularly in red areas. And we've been doing that anyway by virtue of our routine sort of psychology work being reduced, and has been able to redeploy psychology staff. But of course, that's just a temporary fix. And what we understand and are coming to understand is that the need for psychological support because of COVID will extend far and away beyond the waves and any subsequent waves. And in practical terms, we're also providing food and drink to the staff on those red areas who are clearly, you know, using PPE very heavily, and that's very exhausting in and of itself. The next thing around staff in relation to the second wave, which is very different to the first, is the plan to do routine staff testing for asymptomatic staff. So, of course, we have been used to providing testing facilities for staff who exhibit symptoms as part of our offer from our own laboratory testing capacity. What is proposed to happen as of next week is that all staff will be offered what's called a lateral flow test, which is the same sort of testing that is now being used in Merseyside for mass population testing on a fortnightly basis. And so there are 34 trusts who are currently piloting this, and we are awaiting the outcome of their learning. They're only doing it for the rest of this week, but from that, it's expected that there will be some guidance and then subsequent supplies of the test that will land in our trust for commencing this next week. The immediate concern is what will that do to our sickness rates? Because if staff are asymptomatic, of course, and they are proved positive in the test, what will happen then is that they will have a swab test. If that is positive, they will have to go off and of course, self-isolate. And, you know, let's hope that they don't require hospitalisation or any kind of major treatment, but who knows? At that point, you know, are we going to have real problems with staff absences and sicknesses? All we can look to really is an area in the northwest where this has already happened, where the staff rate of asymptomatic people being positive was about 1.3%. So it will have an impact, but it's hoped that it will not be above 1.3%. So that's the real focus of what has been happening in the trust in regards to people. If we move on to partners, we've already referenced, and Pat has specifically, the report by Professor Denzana Kinnair. This was a review that was requested, commissioned by West Yorkshire and Harrogate Partnership. It was actually kind of commissioned, I think, ahead of the publication of the phase 3 letter and its accompanying appendices around the impact of COVID on those with inequalities. Its aim really was to review what, as a partnership across West Yorkshire, we could do to address those health inequalities that we had observed for Black, Asian and minority ethnic communities as a consequence of the first wave of COVID. I participated in the launch event, which was on the 22nd of October. So there are 4 key areas that come out of that report that we are required now to address. And the first is ensuring that the partnership's leadership is reflective of its communities, which speaks to the point that we've already touched on at length about senior leadership of our organisations, because the leadership of the partnership is drawn from the senior leadership of the constituent parts of the partnership. Using information to make services meet the needs of different groups, and reducing inequalities in mental health outcomes by ethnicity. And alongside those areas of focus are a number of recommendations. As the designated lead on the board for health inequalities, I propose to establish an Inequalities Council. And this will build on the work of our existing Diversity, Equality and Inclusion Steering Group, but with a much broader remit and a much broader membership. Supported by Pat as the chair of our People Academy and by Kez, with whom the board are familiar, our Equality and Inclusion lead. Our first job card really will be to review this report alongside our existing equality, diversity and inclusion work plans and the additional areas of action that are outlined in the phase 3 letter, bringing together a comprehensive work plan and areas for specific actions that will then be discussed in what I propose to be a workshop setting for in preparation for the establishment and the change from our original terms of reference for the ED&I steering group and the Equalities Council. What I want this to be is an inclusive space. So I'm hoping that we will come to a view at the meeting on the 23rd of November, which will be the final meeting of the old group, where we can expand the membership to include people, I would suggest, like our staff governors, some representation from non-executives, and also the chairs of all the networks that we have. So that it becomes an area which is overseeing every element of inequality. And also we look with two parallel areas of focus. One is our staff and what we do to create the environment of inclusivity and equality within our organisation. And the second is what we do as an organisation to address health inequalities across our wider communities, which relates directly to the 10 big ambitions and our people, partners, place strategy. So those are the two parallel areas that I hope to address through this mechanism and report back, Chair, directly to the board on these matters. The second area I want to reference in relation to the partners, the partnership, is the very good news that the second vascular hub, as part of the vascular network in West Yorkshire, will go live on Monday, and it is at Bradford. So BRI will be the site on which complex vascular interventions and operations are conducted on behalf of the West of West Yorkshire trusts, which include Calderdale and Huddersfield, ourselves and Airedale. And it will not be a surprise that we thought very long and hard about the appropriateness of undertaking this move at this time in the middle of the second wave of this pandemic. But in conversation and discussion with all colleagues across all three trusts, and I chair the steering group for this, we've been meeting on a weekly basis in the run-up to the implementation date, and we have a number of checks and balances in place, which would suggest from an operational and a clinical point of view, people are content and assured that it is the right time to make this change, and it is for the benefit of those vascular patients who, after a long period of delay due to the first wave of COVID and the pause that was put on the public consultation, we really want to press ahead and make our vascular services more resilient and responsive. So that's some good news in and amongst. And then the final P in that PPP strategy is the place. And John's referenced Actors 1, which continues, and we're very keen to see that continue through this second wave. But I'll just talk for a brief moment about a specific piece of work that we have embarked upon as partners in place under the Actors 1 programme, and that is a revision of the strategic partnership agreement that binds all the constituent parts of our place, i.e. all the NHS providers and commissioners, together. This has been in existence for a number of months. In fact, longer than that. I know it was 2 years at my arrival in the trust by a long way, but we feel it's a good time to revisit that in order to strengthen it and arguably give it much more authority and autonomy as a decision-making process, as well as one that just calls partners to arms. And to that end, there is a design group that has been constructed, and we are working with Hill Dixon, who were the first legal support team to put the original SPA together, to really kind of enhance that in scope and breadth. And as part of that, we have proposed John will be our lead on that, and Max, as the chair, will also input into that process. So that's all I have to say, Chair. Happy to take questions.
Thanks very much, Mel. It's very helpful, very thorough. Looking round, are there any particular questions of Mel? Mel, can I just be sure what you meant by the Inequalities Council? Was that an internal organisational council? Yeah, I thought so, yeah, rather than wider partners at this time. It's our people. Yeah, thank you. Thank you, that's fine. Any questions of Mel? No? Thanks very much, Mel. Very useful and thorough update. Thank you. Okay, so I'll move to closing off the meeting now. We'll return to the board assurance framework and risk appetite statement. And in light of the dashboard information we've heard and the opportunity to revisit the integrated dashboard, just ask whether anybody has any comments or thoughts on the text in the board assurance framework and risk appetite statement. As a board, we are asked to consider it and consider whether it fairly reflects where we believe we are. Are there any comments or thoughts, or are we content to note that board assurance framework? Okay, thank you. I'll take those as noted. And then we have two governance items to note, which are the safeguarding reports. The Safeguarding Adults Annual Report for 1920 and the same period report for Safeguarding Children. These would normally have gone to Quality Academy first, but given the changes we've had at the moment, I was asked if they could come here and agreed to that. So I am conscious that people may have read them, may have some thoughts or questions in relation to them. So I'll just open up whether Karen wants to say anything specifically about those, and then just check whether there's any detail required. I mean, they stand for themselves, and I've had the chance to look at them, so I'll see what people think. Karen, do you wish to say anything about those two safeguarding reports?
So I will be brief. I'll take both reports together. So they've come to board because they're getting a bit out of date now, because they refer to last year, or last financial year. There is a requirement for board to have sight of these reports, and normally at this point you'd all be getting your annual safeguarding training updates as well. So we need to think of a way of doing that, potentially online. So a few key points to note, if I may. So Safeguarding Adults, you will notice that they've moved to 7-day working to support during COVID times. They've seen reduced activity in the period of March and April, March, at the back end of the last financial year, but increased complexity, I would suggest, with the patients they were seeing. And a huge positive in the Safeguarding Adults report, which was we substantively appointed a learning disabilities nurse, which is paying off greatly, and Caroline is doing a fantastic job. So moving on to safeguarding children, you'll note there's discussion in there around maternity services and the attendance of midwives going to case conferences. I'm pleased to report that we put additional investments into maternity to enable that to move forward. And there's also an additional report for this year around children on adult wards. So we have a system in place now to flag anybody under the age of 18 that may be on an adult ward, because children, of course, do have a choice from being 14 years and over. Some choose to be on adult wards, not paediatric wards. But we can flag them and they all get reviewed by a senior paediatric nurse to make sure that we are meeting their needs. You'll also note that there's a number of risks that I've described as well in relation to the strategic risk register that link to this, including mental health referrals and then the children with mental health conditions attending the hospital as well. So I'll pause there. A very positive report from an excellent team.
Questions or comments, colleagues, regarding our safeguarding reports? Nothing I can see. Are we content to note both those reports? Yeah. Thanks very much, Karen, and thank you, board, for noting those two reports. Thanks. I'll move now to closing off. There was no other business. Can I propose that during the course of the meeting we have considered matters that need to be escalated and captured and directed towards the proper place? And before I close our public board meeting, can I just draw board's attention to the fact that this is our Chief Medical Officer, Brian's last public board meeting in role as Chief Medical Officer or Medical Director for Bradford Teaching Hospitals. And obviously ask the board to endorse me in thanking Brian for everything he's done for this trust. Brian, particularly in recent times, I've seen you as a real advocate for system thinking and modern thinking, and thank you for that. You've brought our thinking and debates into a different domain. And of course, a hospital does not achieve a good rating from CQC without a medical director that's steering that and directing us in that way. So, Brian, I don't know if you want to say a word to colleagues, but I do want to thank you on behalf of the board for everything you've done for this hospital trust.
Very kind, Chair. Thank you. I may not be at my best. I'm recovering from COVID, for those that don't know. I'm now on day 9, but I'm getting there. So I would certainly urge you, if you can avoid it, please do, because it's not what you want. It's been an unbelievable 5.5 years, really. It seems like only the other day, and many of you weren't on the board 5.5 years ago. If I look back and I think, where is the organisation, where are patients in terms of their quality of care? It's a completely different level. And I think when I think about the contribution that we make as a board and the contribution that we've heard even today about the frontline staff, I think that one of the messages that I've probably taken away is that while standards and statutory requirements are important for us, we've always got to remember what we're here to do, which is to deliver better patient care. And I think that where we're heading and where the organisation is heading, I can see a great future. And it's been amazing to be part of something going from where we were 5 years ago to think of what we're now sitting on as a potential, going from good to outstanding with the team that's in place. And I'm pretty confident that Ray will be far better at many of this than I ever was and ever will be. But I am really excited to have been part of that journey. I can't imagine how we as a board cannot achieve what we're capable of. And if I read that you haven't achieved what we're capable of, I might write a letter of complaint for the first time ever in my life. I never know what words to use in these scenarios, but having moved from Leeds, and there's many of us who've done that now, I was probably a bit of a pioneer to move from Leeds and come to Bradford. And I think seeing what Bradford has to offer my final statement is stop worrying about what everybody else is doing and focus on what Bradford is doing, because it will take us way ahead of anywhere else, because the population we serve is like no other. And if we do it in Bradford, and we can, then everybody's going to follow us rather than us worry about following other people. And I thought I'd never, ever say that, having been a specialist in a very large tertiary centre. But it's been absolutely remarkable what we've turned around in this organisation. And to be involved in the appointment of people on this board, including the chair, and sit on that stakeholder panel. I remember the chair's comments when he came in, he said, "I want to be your chair." It almost was, it doesn't matter what else you say after that, Max. He was the only one that came in and said he wanted to do it. But please do not forget what we're here to do, because I think that is what makes us feel proud. And thank you ever so much for everything. It's been remarkable.
Well said, Brian. Thank you. Yeah. I know you still have some commitments ongoing with us, of course, Brian, over the coming weeks, but it's right at this public board that we recognise your contribution and we thank you. So thank you very much, yeah. Okay, I think we've come to the end of the board meeting, everybody. Thanks very much. We'll close the meeting now. We're going into a closed meeting, of course. Do you want to just get on with that straight away? Shall we go to the next meeting? I think we can deal with matters in the closed meeting fairly sharply. And in so doing, finish at about the sort of time we said we always would anyway. Yeah. So should we do that? So I'll end this meeting now, and we'll go straight to the closed board meeting and deal with matters there. Yeah. Recognising if I'm doing that and people just need to take a moment, I understand. But we'll go straight to the other meeting and start it. Okay. Thanks, everybody. The meeting is closed. We now move into closed session.